Welcome to an ONC Artificial Intelligence Showcase, Seizing the Opportunities and Managing the Risks of Use of AI in Health IT session. My name is Tom Deneen with Kaufman and Associates, and will be assisting with the logistical support for Zoom this morning. To provide comments, please open the chat box, which is located towards the bottom part of your Zoom interface. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. If you need technical assistance during the session, please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. All phone and computer lines have been muted. I will now turn it over to Stefan.
Trying to make sure you guys can still hear me. It said I was muted. Thank you to Tom, and thank you to everyone attending today, choosing to spend their afternoon or early morning with us and half of the day for an ONC Artificial Intelligence Showcase. The title for our event today is Seizing the Opportunities and Managing the Risks of Use with AI in Health IT. And although I will be serving as your event MC, you will be hearing little from me and more from many other experts, both from federal government as well as non-government stakeholders across the industry. I'm excited, although I do not have 2 turntables and a microphone, but as MC, I do get to tee up and introduce a number of presenters, in fact, over 30 presenters throughout the day. And with that, I do want to first turn it over to our national coordinator, Mr. Mickey Tripathi.
Great. Thanks, Stefan. Can you hear me okay? Just want to do the sound check. Great. Well, thank you, Stefan. And I just want to welcome all of you here. For those who I haven't met yet, my name is Mickey Tripathi, and I have the honor of serving in the Biden administration and the American public as the National Coordinator for Health Information Technology. Let me first just do a quick recognition that one of my esteemed predecessors is here joining us as well, Dr. Rob Kolodner. Hey, Rob, thank you for joining, and just wanted to to welcome you and to welcome everyone who's joined today. On behalf of ONC, I want to welcome all of you to be sure, to what I think is going to be an afternoon packed full of enlightening and encouraging presentations. Through today's showcase, our goal is that each of you learn something new and come away with a feeling that the federal government and others outside of the government in the healthcare industry are working toward advancing the responsible, trustworthy use of AI in health IT. Despite all the progress and promise, we know that there are still some gaps that remain to be addressed. And that's part of what we want to be able to talk about today. And hopefully through the closing panel and your own critical evaluation of what you've seen today, we'll be able to set the table for future discussions about what work still lies ahead. Let me give you a little bit of ONC 101 for those who aren't familiar with us. We are the principal federal entity charged with coordination of nationwide efforts to implement and use health information technology and electronic exchange of health information. And AI is just one small topic that intersects with many of the areas in our portfolio of work. We work on interoperability, we work on certification of EHR systems, we work on promulgation of standards for interoperability, and we also are increasingly focused on health equity, as we'll discuss later today, I think, a little bit, and with the policies related to sharing information that are in the Cures Act regulation that come from the 21st Century Cures Act that many in the industry may be familiar with, as it's called information blocking, but it's with the rules and that are basically about preventing interference with the sharing of information among authorized entities as well as with patients. How does all this relate to ONC? Over the last number of years, we've invested time and resources looking specifically at AI and health IT. In 2017, in an effort to assess the potential realistic implications of AI applications in health and healthcare, and to understand the risks, ONC and ARC, the Agency for Healthcare Research and Quality, with support from the Robert Wood Johnson Foundation, turned to Jason, who many of you may know is a scientific advisory panel that the federal government turns to from time to time. We turned to them to consider how AI might shape the future of public health, community health, and healthcare delivery. We specifically asked Jason to focus on technical capabilities, limitations, and applications for AI in health and healthcare that can be realized within the next 10 years. That report lists a series of findings about the current state of AI in health and healthcare and offers recommendations that could accelerate the use of AI in and out of the clinical setting. What was clear from that report was that without access to high quality, reliable data, the promise of AI won't be realized. The increased availability of digital health data could allow for the use of AI in clinical practice, but we know there are a lot of issues regarding the quality of existing data that have to be addressed. And those are, general ecosystem issues, which is, sort of the biggest part of the challenge. Though many of us already use our smartphones and other smart devices in our daily lives through the availability of open APIs, there's still concerns about how health data can be integrated into new tools, as well as the equitable distribution of these potentially powerful tools. The increased availability of high quality data, digital health data, can facilitate the use of AI in clinical practice. The accessibility and privacy and security of that data also has to be addressed. I strongly encourage you to read the report and an associated ONC blog post that was co-authored with our colleagues at ARC, titled "Hype to Reality: How Artificial Intelligence Can Transform Health and Healthcare." So skipping ahead to more recent events, ONC conducted multiple CDS workshops, and there were at least 2 of them in 2021. And we funded a LEAP Award, Special Emphasis Notice Project, which is an innovation award focused on evaluating health IT tools to make electronic health record data research and AI ready. Additionally, I also want to highlight an example of some of the great work done through our portfolio of PCOR projects, the patient-centered outcome research. Specifically, there's one focused on training data for machine learning to enhance patient-centered outcomes data infrastructure. And through this project, ONC, in partnership with NIH, the NIH Institute of Diabetes and Digestive and Kidney Diseases, advanced the application of AI/ML in patient-centered outcomes research by generating high-quality training data sets for chronic kidney disease use cases, specifically predicting mortality within the first 90 days of dialysis. That final report, the implementation guide, and the associated code developed through that project can be accessed on our website now at healthit.gov, and I encourage you to check them out, please. So speaking for a second, before I turn it back over to Stefan, I wanted to, I definitely wanted to talk about health equity for a second, and ONC's, very specific and focused and growing interest in addressing algorithmic bias and its potential impact on health equity in particular. As we know, all algorithms are biased, and they're all biased in their own ways. And it's important, first and foremost, to have sort of recognition of what are the sources of that bias. How do we disclose in some type of meaningful way what underlying biases might exist in particular algorithms, and then how does that help to inform the users of those algorithms as they start to think about applying those in particular settings. You may have heard me say this before, but promoting health IT and in particular, as we call it in ONC, equity by design is a top priority for my office certainly, and for the Biden administration. And in particular, and we have a number of things that are underway there, but algorithmic bias is certainly at the close to the top of the list, or at the top of the list of things that we're looking at. Partly because we also have a very unique perch in the healthcare ecosystem, I think, in terms of the direct relationship that we have to provider organizations and to the health IT systems that we certify and that are used by the majority of hospitals and the majority of ambulatory physicians in the country, and the standards that relate to the data, the standardization of data, like the US CDI, the US Core Data for Interoperability, as well as other standards that are associated with certification. All of those are the reservoirs of data that are then used for the training of algorithms. And then the EHRs themselves are the vehicles that are used for creating the tools. In many cases, with some vendors, obviously there are non-EHR vendors as well that are developing algorithms, but the EHR vendors themselves are also doing that. And so to the extent that the data that is we have a very unique sort of a direct link to, as well as the tools that are in EHR systems, all of those are things that are of great interest to us as we think about what type of role we might be able to play to helpfully help the industry move forward in these complicated issues related to AI, bias, and health equity. So this work also builds on our efforts to integrate standardized SDOH data in more meaningful ways. Many of you may know that in the US CDI version 2 that we released in the summer of last year, it includes 4 social determinants of health categories, as well data elements, as well as SOGI data, sexual orientation, gender identity data, as guidelines now, and then ultimately could turn into voluntary and then potential certification requirements. All of that becomes a part of the corpus of data that is available for algorithms and for machine learning technologies and the associated applications that would derive from those. So, strong data governance practices are, a key part of that, as well as we sort of think about the issues that are here in front of us. And all of that is, why ONC is, definitely taking a very good look at this and has deep interest in understanding how all of you are thinking about it and what we can learn from all of you and how we can all work together to move forward. So, whether that's related to poor model assumptions design, reliance on insufficient data inputs, lack of post-implementation performance monitoring and evaluation, understanding how bias can present through the use of AI and health IT across the AI lifecycle, it's critical to ensuring that we all have the same access to and quality of healthcare. So we very much look forward to continuing working together with all of our federal colleagues on this issues, as well as all of you. Many of you are going to be seeing today the presentation of all of the different work that's been going on at the federal side, as well as in the private sector. And we very much thank you for your participation, for all of your contributions, and we very much look forward to working with you very closely on these really important issues going forward. So hopefully all of you will continue to join us in this journey. Today is just one day, but we've got lots more to come. So thank you again, and let me turn it over to Stefan again.
Thank you, Mickey, for those amazing remarks to kind of get us centered and grounded for the day. We really appreciate it. Your leadership has been immensely valuable towards having everybody work together more closely on this. So with that, I'm going to go ahead and turn it over to another one of the amazing leaders that we have within our federal government, Ms. Lynn Parker with the White House Office of Science and Technology Policy. Lynn?
Thank you so much, Stefan. And hello, everyone. I very much appreciate the opportunity to provide a few remarks on the U.S. approach to AI. As all of this audience, I'm sure knows, AI has become one of the most impactful technologies of the 21st century. And it provides both opportunities and challenges in nearly every sector of society. So of particular relevance to this meeting in the area of healthcare, AI has immense potential to accelerate medical research and support the health and well-being of all Americans. So to give you some insights into how we are approaching AI within the US federal government, I'd like to take just a few minutes now to give you a very brief overview of the National AI Initiative. So if we could have slide 2. The National AI Initiative was launched a year ago with 3 primary objectives. First, we want to ensure continued U.S. leadership in AI research and development. Second, we aim for the United States to lead the world in the development and use of trustworthy AI systems in the public and private sectors. And third, we must prepare the present and future U.S. workforce for the integration of AI systems across all sectors of the economy and society. And of course, we also want to make sure we're coordinating all of these activities across the federal government. Next slide. The legislation that created the National AI Initiative also created the National AI Initiative Office within the White House Office of Science and Technology Policy, which I lead in the National AI Initiative Office. And this office acts as a coordinating hub to work across agencies and to achieve the goals of this initiative. So Clearly, there are a lot of AI efforts across the federal government to coordinate. As the next slide shows, there are a large number of agencies contributing directly to the National AI Initiative. And even beyond these agencies, nearly every agency of the federal government has important activities ongoing that are related to AI. Stefan, you've got that slide. Yes, thanks. So to organize and coordinate all of these federal efforts, we're pursuing policy initiatives along 6 key pillars, as shown in the next slide. So first, in AI research and development, our priority is to sustain investment in our national innovation ecosystem to ensure that the United States continues to produce cutting-edge breakthroughs in trustworthy AI. This is happening across a number of specific R&D efforts. So I'll mention one major area of activity in particular, which is our work in building up large-scale multidisciplinary research in AI. We've now launched 18 large-scale multi-partner AI research institutes across the nation, led by NSF, together with other federal and private sector partners, with investment so far totaling $360 million over 5 years. More institutes are anticipated in the coming years. A second area of emphasis is in AI infrastructure. We're focused on advancing efforts that broaden and democratize access to cutting-edge computational resources and high-quality data sets and test beds to advance AI R&D, to support equitable growth, to expand AI expertise, and to enable the application of AI to a broader range of fields. A key initiative we're working on in this area is a concept we're calling the National AI Research Resource, which aims to strengthen the U.S. AI innovation ecosystem by supporting foundational AI research, by advancing use-inspired AI research, such as in healthcare, and increasing the number and diversity of researchers and organizations participating in AI research. Third, the United States aims to be a world leader in the development and use of trustworthy or responsible AI. These are systems that provide innovative capabilities while protecting privacy, civil rights, and civil liberties. Advancing trustworthy AI requires a multifaceted approach, which includes R&D investments that address key technical challenges, the development of metrics and assessment tools that will measure and evaluate AI trustworthiness, engagement in the development of AI technical standards, and governance approaches for the use of AI in both the public and private sectors. A fourth area of emphasis is in our education and workforce development area. We're prioritizing the training of an AI-ready workforce. Our goal is to fill the AI talent gap and prepare U.S. workers for jobs of the future by implementing policies that ensure a diverse, inclusive, and knowledgeable workforce. We would like to see the integration of AI-related concepts in all levels of schooling, from pre-kindergarten through postdoctoral positions and including community colleges. Educational progress can be accelerated by building up coalitions of private sector, nonprofit, and government groups to achieve effective AI education at scale. Fifth, international engagement is a strategic priority. The United States deeply values our collaborations with like-minded allies in advancing the development and use of trustworthy AI. We have a number of ongoing engagements and collaboration agreements with like-minded nations so that we can work together to not only agree on shared principles for AI, but also to implement those principles in a way that upholds human rights around the world. And finally, a sixth area of emphasis is in the use of AI in government. We're working to promote the innovation and use of AI where appropriate to improve government operations, to transform federal customer experience, and ensure national security consistent with established principles and ethics frameworks for trustworthy AI. We see progress across all 6 of these priority areas as imperative toward our overarching goal of strengthening AI innovation and developing AI advances that are used in a responsible manner, not only in the United States, but around the world. So let me conclude with the last slide by encouraging you, if you haven't discovered it already, to please check out ai.gov. This website provides much more detail in all of these areas and related areas as well. So with that, I'll wrap. Thanks again for the chance to talk with you. I wish all of you a very successful meeting. And back over to you, Stefan.
Thank you, Lynn, very much for your comments and your work leading across all of U.S. Federal government, pulling all our agencies together to meet the needs of the legislation and the executive orders that have come down around this issue. Actually, as a build off of one of your last points about the focus on AI in government settings, we were going to have Oki Mek, the Chief Artificial Intelligence Officer for HHS, present a little bit about the Office of the Chief Artificial Intelligence Officer, which is focused at coordinating AI adoption, utilization, implementation across all the health and human service agencies. Unfortunately, at the last minute, he was unavoidably detained. So I will cover a few of his short slides. He said, as a member of the AI Council and a board of advisors for them, that I was more than capable. So I'll try to do him justice. So one thing to know is that there was an AI strategy, an enterprise AI strategy document that was put out a little over a year ago with input across all the federal health and human service agencies to try to figure out how we can, number one, develop an AI ready workforce and strengthen AI culture, to encourage healthy AI innovation and R&D, to democratize foundational AI tools and resources, and to promote trustworthy AI use and development across the federal healthcare agencies. Part of the governance model was to come up with a couple of key ways of bringing together the AI community across HHS. One is the development of an AI council, which will be launched officially this year. The second is to have broad participation in that council, both direct division primary representatives as well as additional representatives, depending on the interest level from those agencies. And then to develop an AI community of practice for anybody to join across HHS internally to share best practices and build that kind of community of shared learnings. As far as the key council overview, I'm just going to quickly touch on the fact that the key functions are to govern implementation of the strategy and to develop AI guidance for internal use, to enable and accelerate AI priorities, to cultivate partnerships across agencies, and to sponsor that community of practice. And the topics that they're going to typically be addressing would be issuing formal recommendations to the Office of Chief Information Officer and other departments, to select department-wide AI priorities, approve cross HHS AI work products, and improve on how the AI Council operates overall. To help support the work of the Council and the agencies implementing AI at HHS is the development of a trustworthy AI playbook. And the objectives are to promote understanding of the principles outlined in executive orders and other requirements, to provide guidance and frameworks for applying trustworthy AI principles throughout the AI lifecycle, and to centralize relevant federal and non-federal resources, and to serve as a framework for future HHS policies. So it's not a formal policy itself or a standard itself, but rather, and it's not an exhaustive guide on building and deploying AI solutions, but rather a collection of best practices and a playbook for how to get started in pursuing your AI adventures at different federal agencies. The principles that it's built upon are similar to what you're going to be hearing throughout the day today, which is a good thing, showing that government and in the private sector and others outside of government are aligned on this. But we think that 6 of the key components for trustworthy AI are transparent and explainable, fair and partial, robust and reliable, responsible and accountable, safe, secure, and to address privacy. And of course, these have all been mapped towards the executive order principles and the OMB principles that each agency across federal government was charged with addressing. And so for more information on all of this, as I said, unfortunately, I tried to do my best to cover Oki's remarks. But if you're still wanting for more information to go a little deeper on this, they recently, in the last week or two, launched a public website that details the AI statutes and authorities that all this work is organized under, the HHS AI strategy itself, the trustworthy playbook, accomplishments will be posted there, and AI activities and priorities will also be promoted through that website as well. So feel free to visit this website. And yes, these slides will all be posted after the event, so you can go back and click on the hyperlink if you're not quick enough to manually to write down what you see on the screen in front of you today. So thank you to all the opening plenary speakers, to Mickey, to Lynn, to Oki for their leadership in helping organize interagency and collaborations with non-federal entities on this topic. And now I'm excited to dive into the AI showcase. As the format goes for this event, we've got 3 parts focusing on different topics. The first is advancing responsible AI in health IT, or guiding principles. Builds a lot on what we just talked about in our opening plenary. And we've got a number of both federal agencies, a couple of international representatives, and then also some non-government representatives who will be presenting on this topic. Unfortunately, there was a number of other presenters we wanted to include throughout the day today, especially in this area. But unfortunately, we weren't able to get them included either due to time constraints or unavailability of schedules. But we look forward to featuring some of their work in future ONC events as well, and potentially further workshops in the future. But for today, we've got NIST, we've got the VA's Artificial Intelligence Office. We have our good colleagues at AHRQ, who we've been working together closely with for a long time. We've got Canada Health Infoway, NHSX from England, the Linux Foundation, Connected Health Initiative, and Intermountain Healthcare. And maybe our colleague at Intermountain Healthcare would also be willing to share a little bit of details about a recent announcement on a coalition that they're part of that also we weren't able to fit into this agenda for today, unfortunately. I also want to encourage everyone to follow along online at Twitter. You can use the hashtag healthit_AI. And then also feel free to tag at ONC_healthIT, our agency's Twitter handle, to share in an online community discussion through Twitter. So with that, as a quick time check, I think we might even be a couple of minutes ahead of time, but hopefully our first speaker during the showcase, Elham Tabasi from NIST, was ready to roll. Elham, are you available?
Yes, I am. Can I get a sound?
Outstanding.
Sure. That
Thank you for being on early. Appreciate it.
Of course. Can I get a sound check? Can you hear me okay?
We can hear you great.
Perfect. Okay, so thank you so very much for the invitation. Super happy to be here and talk about some of the initiative, particularly the AI risk management framework that we are developing. Next slide, please. I'll start by saying a very, very short overview of NIST. NIST is, we call ourselves Industry's National Laboratory, and has a broad portfolio of research from building the world's most precise atomic clock to developing guidance for cybersecurity, and now working on AI and AI risk management framework. NIST has a long-standing reputation for cultivating trust in technology. We do that by participating in development of the standard and metrics, both domestically and internationally. Our role is to strengthen measurement science, provide technical contribution to standards, to make sure that the standards that are developed and the technology that are going to be developed are secure, usable, interoperable, reliable, or in other words, trustworthy. And as we all know, this work is critical in the AI space to ensure the public trust and confidence of this rapidly evolving technology. And we all know that depend on the link that you click on and the article you pick up to read, there are informations that promise you a very, very, very bright future, raise productivity, improve the quality of life in all aspects with AI. And then there are some other voices of concern that it has negative impact on job. It can exacerbate the trend of the rising inequality, and even some articles that talk about threat to humanity. And we all know that the truth is somewhere in between, and that's exactly what we are coming, our contributions is coming in place. So globally, researchers, developers, consumers, they all have expressed their desire and need to understand technical and societal risk related to AI technologies. And we heard from Lane, and we heard from other agencies that they're all working on many different policies and principles, and where all those landscapes are evolving. We at NIST try to provide scalable research-based method to assess risk and advance trustworthy approaches So AI can serve all people in responsible, equitable, beneficial ways. Next slide, please. And to do that, really what we are trying to do is on the bottom layer, first of all, understand what trust and trustworthy means, what constitutes trust, and what are the characteristics of a trustworthy systems. So we are trying to figure out what are those building blocks for trustworthy AI, and then for each of them, bring the community on a shared understanding of that concept. We all know, we heard that we want AI to be unbiased, but what does really bias in AI means? We heard that AI needs to be fair and explainable. What does that really means? So what we are trying to do is bring the whole community together to provide that shared understanding, and then once we know what it is that we want to measure, build efforts to advance evaluations, metrics, and benchmark. And these all give the right building blocks for a risk management framework. Next slide, please. I just want to quickly talk about the building blocks for the trustworthy AI. We heard from Stefan that HHS is also thinking about this, and this is not any different from many of the AI principles. We want the AI system to be accurate, but on top of that, we want to be robust to many different environment and conditions that they was not seen during the training. We want it to be reliable. We want it to be secure to many of the different vulnerabilities that we heard and see in the news and in the articles. Privacy preserving, explainable, undiscriminatory, safe is all of them the concept that we heard, and we consider these as the properties and characteristics of trustworthy AI. And of course, on top of that, principles such as transparency, fairness, and accountability is also important along the life cycle of AI. Next slide, please. We have built research programs around all of them to understand what bias means, what explainable AI means. But what I want to emphasize right now is that development of the AI risk management. We have been asked with the whole community, and then also tasked with the Congress to develop AI risk management framework. Our approach has been like many other work that we had done at NIST. Next slide, please. Engaging the whole community in what we do. So in the development of the AI risk management framework, we start by a RFI that we send it out in summer. 100 or so responses received are posted in our website. Based on that RFI, we put a summary of RFI, and we had a workshop in October. Recording of that workshop is on our website. And then we did a concept paper that's out for public comment by January 24. Basically what it does, it lays out the outline of this framework, basically talking about functions such as map, measure, manage, and govern. And then we will flesh out the mapping of AI risk, the measuring and managing of the AI risk. Based on the comments that we hear, to develop the first draft of the framework and a workshop in spring, and then iterate a couple of times with the goal of publishing the risk management framework by winter 2023. Next slide, please. And that might be all of my slides. I hope I was on time. This is our contact information for the AI risk management framework, and the website for several of the documents and result of the research that we had on bias, on explainability, on security, along the way with the work that we're doing to understand how to do the measurement and evaluations of the AI systems. With that, I'll stop, and I'm happy to answer any question.
Thank you, Elham. Unfortunately, we don't have a lot of time packed in for questions, but we are sure that people will reach out to you with your contact information here. They may put some things in the chat if you want to try to monitor that, but I know you may also have to step away. So certainly appreciate you taking the time to quickly provide us with an update. We know that folks will be feeding from a fire hose throughout the whole day, but you did a great job on timing, and really appreciate all the quality content that you shared with us. So with that, next, we're going to quickly transition to our colleague, Gil Alterovitz, who's the director for the National Artificial Intelligence Institute at the VA. Gil, if you go ahead and turn on your microphone and your camera, I'll go ahead and turn it over to you.
Great. Thank you very much for the introduction, and great to see a lot of familiar faces presenting and on this session here. So what I'll be talking about is about enabling trustworthy AI. Some of the experiences from the VA, which is the nation's largest integrated healthcare system. If we go to the next slide, we'll see kind of, why AI at the VA, there's a lot of reasons why we can really leverage AI to help on our mission in terms of helping veterans, providing care and benefits and so forth. There's over 9 million active patients, making it that largest integrated system, as we mentioned. But not only that, there are over 100,000 doctors and nurses in the VA. And actually, many people don't know this, but nearly 3/4 of all US doctors are actually trained at the VA, and a significant number of nurses as well. Some of them stay at the VA and some then go to other hospitals after their training. There's also a wealth of genomic data that can help in our mission, medical images, a lot of in telehealth, and facilities across the country. So really national in scope. If we go to the next slide, we'll see that, and this follows on a number of the discussions that were just presented around, there have been a couple of executive orders around promoting the use of trustworthy AI and maintaining that leadership in AI, as well as strategies, the National AI R&D Strategy, a few other strategies, and the National Defense Authorization Act that comes out that recently called for that National AI Initiative. So what we're trying to do is make sure that we're working to align with all these different initiatives and working to implement in a way that can really help in our mission. So if we go to the next slide, we'll see that we just recently announced or came out with our VA AI strategy, which really sits around that vision to improve the outcomes and experiences of our veterans by developing trustworthy AI capabilities. VA was actually one of the first federal agencies with an official and explicit AI strategy. And in doing so, we brought together over 20 some offices, and there's a link there if you'd like to check that out, as well as other guidance that we have around working on AI with industry as well. If we go to the next slide, we'll see kind of an example, actually a motivating example around VA working with different partnerships with different outside organizations. In this one, it was around 48 hours in advance, and that really enables us actually to take preemptive action and actually stop essentially the conditioning from happening. So that's kind of a new way to approach this. It leverages deep learning and some of the really latest technologies, which was really kind of helped set a model for how we've been thinking about doing different collaborations and potential partnerships with industry, with other agencies. And one of the things that we've done is the AI Tech Sprint, which allows us to engage with different organizations over a period of time. If we take a look at the next slide, we'll see one of the results of that, which we're now piloting, but it originally started as basically an entry in the AI Tech Sprint in the past. And what the story or the motivating condition here is that non-adherence to medications can actually account for up to 25% of hospitalizations each year in the United States, and around 125,000 deaths per year. So if we go to the next slide, that was a motivating factor for this application, which, as you can see in the video, what it does is you can have the veteran will be able to just show their phone camera, essentially, their medications. It then, using machine learning, looks at the picture, detects, finds what medication it is, tells them and links to their own medical record if they choose to give it permission to do that, and says if they are missing a medication or they have a medication that is not in their medical record that they maybe shouldn't be taking at that point, and works collaboratively with them on that. So use machine learning in a number of different aspects, both on the image recognition, the matching, and also leverages a number of different agency data sets to make that information possible and available, from FDA to the VA. So if you go to the next slide to wrap up here, really wanted to thank everyone. There's a lot of different ways to engage with the VA. I see actually someone just in the chat message put in the AI tech sprints. That's certainly a way. You can also email us. We have a newsletter, which is kind of featured there at the bottom, which I guess you'll get in these slides, are put into the chat. And we have an AI VA community, which we've recently also opened up to outside of the VA community for those that are interested to learn about the kinds of things that are going on at the VA, how they may be engaging in that and going forward. So with that, I'd like to pass it back to the ONC, and really want to thank you for the opportunity to be here and to present. And great to see, as I mentioned, a number of people in the audience and speakers, familiar faces. Thank you.
Great, thank you, Gil, so much for that. And now you've got the two-timer club here of being part of our API showcase last year and featuring some of those tech showcases. So I'm glad somebody dropped the link to that in the chat. So for others who want to learn a little bit more about that, please feel free to go and click on that, and then as well as revisit these slides once they're posted. All right, so now we're going to quickly transition on to our next speaker from our good friends at AHRQ, who again helped us get that report done with the Jasons, with support from Robert Wood Johnson Foundation. We've got Craig Omshi who's the director for the Evidence-Based Practice Center, or EPC division at AHRQ. And take it away, Craig.
Thanks, Stefan, and thanks for inviting me to speak. I wanted to talk about a review that AHRQ is currently doing, examining the impact of algorithms on racial inequities in healthcare. Next slide. So to begin, I thought I would just start with AHRQ's mission statement for those of you who may be less familiar with AHRQ. AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with partners to make sure that evidence is understood and used. So AHRQ is really about generating and synthesizing evidence to support the improvement of healthcare delivery. Next slide. And the impact of the Evidence-Based Practice Center program at AHRQ is really derived from the partnerships that we develop and the end users who use our reports. So many research funders, such as NIH and PCORI, use our systematic reviews to prioritize their research agendas for funding. Many clinical societies work with us and commission systematic reviews to inform their clinical practice guidelines. And many policymakers, including CMS and others, use our systematic reviews to inform coverage decisions and other policy decisions. Next slide. So in September 2020, Senators Warren, Booker, Wyden, and Representative Lee reached out to AHRQ to ask for a review examining the impact of algorithms on healthcare inequities. And to inform that review, AHRQ released a request for information in March 2021. And that request included 11 questions to the public, gauging awareness of the use of algorithms in healthcare and their potential for introducing racial bias in clinical decision-making. We commissioned an evidence review subsequent to that request for information, and that evidence review is now in progress. Next slide. So what I wanted to do in the next couple slides was share some of the results that we received from the request for information, and then share our progress on the evidence review thus far. So for our request for information, we received 42 responses, about 485 pages of respondents' comments. And respondents included professional societies, industry and other healthcare technology groups, academic organizations, federal and state agencies, payers, and private citizens. Next slide. This slide shares some of the themes that were present in the responses we got in our request for information about this topic. So 18 algorithms were identified that could potentially result in racial disparities in care. Respondents also commented that bias could result from algorithms even when race ethnicity was not explicitly included in the algorithm. There were a lot of comments about the heterogeneity and lack of standardization and how race information is collected and defined, so that information that ultimately informs algorithms. There was a lot of responses around how algorithms are often developed using data from populations that are not representative. Organizations also described efforts to update algorithms in use and examine for presence of bias. Some respondents cited research demonstrating disparities in care resulting from algorithms. And lastly, respondents suggested that many were likely unaware of the widespread use of clinical algorithms and their potential for bias. Next slide. So all the information that we received in that request for information, as well as the input of many experts, inform the key questions which now serve as the foundation for our evidence review. This evidence review is underway, and these are the two key questions which are informing the review. The first question is, what is the evidence that healthcare algorithm-informed decision tools contribute to racial ethnic disparities in access to care, quality of care, and health outcomes? And the second key question is, what approaches have been used to mitigate bias in the development, validation, and implementation of healthcare algorithm-informed decision tools? Next slide. And these are the next steps that we're planning. So we hope to have a draft report that we could post for public comment around the summer or fall of this calendar year. We hope to lead a national consensus conference, which can use a draft of this report to put together recommendations. And we hope to complete the final report by fall, winter of this calendar year. Next slide. I just wanted to acknowledge all of the ARC individuals who have contributed to this effort thus far, and you see their names here. I also wanted to acknowledge the contractor who is currently conducting the review, and you see them listed here. Next slide. And lastly, I just wanted to invite you, if you have any comments that you'd like to share with me personally, feel free to reach out over email. The Effective Healthcare website has all of the work that comes out of the ARC Evidence-Based Practice Center program, both on digital health, but also other areas of healthcare delivery and clinical medicine more broadly. And then if you want to sign up for ARC notifications, there's an email to do that as well. Thanks for your attention. And thanks, Stefan, for the invitation.
Craig, of course, we were excited to be able to have you come present today. We were anxiously waiting for some insights as to what was coming from the RFI, and we know that 2022 is going to be a good year to see a lot of that, that end result being presented later this fall and in winter. So thank you so much for that. Now, coming up next, we've got through our Global Digital Health Partnership that HHS leads, in keeping with the spirit of Lynn Parker's comments around international coordination. HHS does lead, and actually ONC is just taking over the role of chair with the Global Digital Health Partnership. We've worked with a couple of different agencies, both at the UK and Canada and others. And Karen Jakar from Canada Health Infoway is here to present on some of their work. Karen, please feel free to unmute your microphone and turn on your camera and take it away.
Hi, Stephen. I'm unmuted. Can you hear me?
Sounding great.
Okay, great. And I also put my video on. Let's see if it switches. In any case, I'll begin. So thanks for having me here today. My name is Karen Jacker, and I work on the Innovative Technologies team at Canada Health Infoway. Canada Health Infoway is an independent, not-for-profit organization federally funded by Health Canada. And Health Canada, you can think about it as similar to the HHS in the United States. We serve all of Canada, and our vision is to achieve better health outcomes for for Canadians through the use of innovative digital health solutions. One way that we approach this is by developing a toolkit for implementers of AI in healthcare, and that's what I'll be updating you guys on today. You can go to the next slide, please. Sorry. So for some very quick background about why we chose to develop the toolkit, Canada has a very rich history in AI, and we developed a national AI strategy in 2017. Our federal government funded the Canadian Institute for Advanced Research, CIFAR, to develop the strategy, and the cornerstone of the strategy is an AI research chairs program. These research chairs are associated with Canada's 3 main research institutes, and about 30% have some affiliation with health research. This interest in health research prompted CIFAR to assemble an AI for Health task force to look at the opportunities and challenges in Canada for AI to make an impact on health systems. One of the key challenges outlined by the task force was how do we accelerate the development and deployment of AI solutions in healthcare? And that's the gap that we're addressing with the toolkit. It's really about equipping healthcare delivery organizations with the tools and knowledge that is required to accelerate the adoption of AI solutions, of course, in a safe and responsible way. So next slide, please. Perfect. So InfoA developed a toolkit for implementers of AI in healthcare. What this is a 6-part module document with a comprehensive set of annexes, and in it we cover a variety of topics that help healthcare delivery organizations demystify AI and what it really means to implement AI in a safe and beneficial way. So in developing the toolkit, we really focused on the net new considerations, things people talked about today that travel with AI. And we think these are the common issues, broadly speaking, that implementers need to think about when adopting AI, specifically in healthcare settings. Our intended audience for this toolkit are project and program teams at healthcare delivery organizations. And also something to note, these are the organizations that are beginning or early on in their AI journey. So smaller to medium-sized hospitals, not necessarily developing AI solutions in-house, but rather implementing AI solutions. I'm going to take a minute to summarize the contents of the toolkit. In module 1, we explain what AI is, talk about why you'd want to adopt AI and why now. Essentially, it's your 101 of AI in healthcare. Module 2 introduces, as I said, the net new considerations, particularly the risks that organizations must plan for when they implement AI-enabled solutions. So for example, we introduced algorithmic bias and unintended consequences and the concept of explainability, as well as other new privacy and security risks that come along with AI. Module 3 is where we explore emerging regulatory landscape around AI. So it's mostly focused on Canadian regulation, but we do a scan of trends around the globe also to see what other jurisdictions are doing to put safeguards in place around data use, data de-identification, automated decision-making systems, and explainability. And the objective of this section is really to showcase the emerging legal response to the uniqueness and complexity of AI systems. In module 4, we discuss and provide practical tools to identify an organization's risk appetite for innovation, as well as a framework to help organizations start thinking about not only what's possible, what's really viable in terms of opportunities to introduce AI, and also their level of readiness to do so. In module 5, we talk about change management. Again, here really focusing on net new considerations, and we pay particular attention to trust and regulation in this module and provide guidance on how to ensure that you're building trust at all levels of the organization and throughout the whole project lifecycle. And module 6 is what I call the meat and potatoes of the toolkit. It really gives guidance on how to develop a governance framework for AI, and it covers people, policies, and procedures that need to be in place to implement AI responsibly. We give key concepts that should steer internal discussions about AI governance, but also help give emerging best practices to help organizations really accomplish this. This is where projects teams also find very practical documentation, for example, a vendor assessment checklist or guidance on what does explainability actually look like for a given AI solution. Next slide, please. So what else might you want to know? So we've launched this toolkit. It's up on our website as of December 1st. We're pretty pleased with the amount of downloads we've had so far. As I said, there's 6 modules, 9 to 15 pages each, 90 pages in total. It's free to download. We're in Canada, so we have a French version and the English version, and you can download the complete toolkit or module by module. And what's next for us? We'll be holding a free deep dive webinar series. It starts early February. It's open to the public. And what we're really going to do is dive deeper into each of the modules of the toolkit. And of course, we know AI is continuously evolving. We believe this toolkit will continuously evolve. So we're always looking to understand, what does the implementer community want to know more about when implementing responsible AI? And you can go to the next slide, please. And we'd love to hear also from this audience. I have our contact information up here. So this is where you can download the toolkit. And please get in touch with us at innovation@infoway.ca. Thank you very much, Stephen, and I'll pass it over to you.
Great, Karen. And before you go, let me be the first to say both thank you and merci. We appreciate your presentation and understand why you put it in multiple languages, your documentation. Think it's a great toolkit you put together. Want to commend you guys on the work there. And I know that although it was developed for the Canadian marketplace, could you just maybe elaborate on how much of it you think is really applicable no matter what market you're in?
Yeah, I tried to get at it. We're targeting issues with AI, not just about AI in Canada. That module 3 about emerging landscape, yeah, it's focused on Canadian regulation. You may want to skip that module, but the other modules are really applicable to anyone, anywhere in the world.
Perfect. I figured as much and wanted to make sure I got you to say that. So thank you so much.
Stefan. Okay, take care.
Appreciate it. All right, so next we're going to go ahead and turn it over to another colleague that we've worked with through the Global Digital Health Partnership, Ms. Leanne Summers, who's head of AI strategy with NHSX, which is part of NHS England, and she's in, I believe, the NHS AI lab. So Leanne, if you would unmute your mic and turn on your camera, you can take it away.
Hi, everyone. Thanks for having me. Yeah, it's been really great to hear the other presentations, and that toolkit looks brilliant. So I'll be checking that out. So thanks to Canadian colleagues. So I'm going to be presenting on how we're turning AI policy advice into action. So NHSX is the policy and strategy unit for digital health within the NHS in England. So we sort of set the policy and strategy direction, and I work as part of the AI, the AI thread through that. If you go to the next slide, please. So we worked with the digital health, Global Digital Health Partnership. So that's countries from all around the world that come together to share best practices for digital health technologies. We sort of led on the development of a policy paper that was a rapid literature review and then stakeholder interviews. I think we had really good representation of 10 different countries, but lots of, I think all the continents were covered. So we had sort of South America, Asia Pacific, US, Europe, whatever, sort of covered there. And essentially what they were trying to do is understand, where are we globally in terms of AI governance? And I think like the other presentations today have touched on this really well. We need to make sure from a policy perspective that we've got leadership and oversight across the whole ecosystem, so this is from the research and development end right up to the deployment and then perhaps even post-marketing surveillance. If we've got an enabling technology, how do we make sure that that's looked at across its whole life cycle? Similarly, people have talked about accepted standards, so both technical standards and sort of data standards. How can we actually make sure that these technologies are able to work and that they're not biased or exacerbating any bias that may exist within the health and care systems that we operate within anyway. And then another key theme was around engagement and collaboration. So obviously it was really identified that we can't develop technologies without involving both the public and clinicians, and then we need to make sure that that conversation is valid. So this was just a rapid review that happened sort of in the end of 2020. My colleagues, as listed at the bottom of the slide here, were involved in that, and we're really grateful for the work that was put into that, and it certainly helped us to think about how we're developing our our approach for AI in the UK moving forward. Can I go on to the next slide, please? So this is just an overview of the AI ecosystem in health and care in the UK. So the NHS AI Lab has been a big proponent of AI use and adoption within the UK. We've had lots of funding available for innovators to support with the development, with the adoption of generation of evidence to support in the wider adoption of those AI technologies. So these technologies have been in place. The first ones are just publishing their preliminary evidence, and we've got some really good results sort of bubbling away there. So that's really exciting. We also work within the context I sort of mentioned of NHSX. So NHSX is involved in the wider digital transformation of the NHS. Its approach is looking to digitize, connect, and transform. Digitize being have we got the kit? Connect, does the kit talk to it, talk to each other, does it talk to itself? And then transform being, what do we do with with any of the data and things that happen, or workforce transformation that we can deliver off the back of that. NHSX has published a data strategy. The data strategy, it's in draft at the moment, but sort of will be going live imminently. And that really helps us to kind of like consolidate what we want to do with data that we generate as part of a single payer insurer system. And we're doing that in conjunction with with patients and the public to make sure that that's a sort of a symbiotic discussion, something that's really, really important for us to get right if we're going to, continue with the trust that people have in us providing their health and care. Also within the context, so sort of like off the back of the policy recommendations, we've been working as part of the G7 this year. We hosted some themes that were looking specifically at AI and medical devices, but we focused on the principles of evaluation for AI models to make sure that they're ethical and safe. And then also for medical devices, what we might do if we, for AI that's moving across jurisdictions, so, like moving between those nations. And we can, I'll put some links in the chat when I finished. Can't quite liaise my hands all at the same time. But yeah, so some of this information is available there. We've recently had, so our national AI strategy has been launched. That's a generic, sort of all applications of AI, but it does have a massive thread through it, with health and care being a big industry for the UK. So, we're really excited to see, what we can be doing to help facilitate the wider adoption and spread of the safe and effective technologies that are available. The national AI strategy that's available sort of on, the Office of AI's website, they've got themes around, sort of generating the standards and the governance around appropriate AI. It's convened by the AI Council that we have nationally, and then there's lots of investments into workforce. Workforce and investments into, sort of some big bets within AI. Can we go on to the next slide, please? So we in health and care are developing out our strategy. Our strategy will probably have some things similar to what Karen was alluding to there, with sort of toolkits as to how we can think about the better deployment. But essentially, we're at the phase at the moment where we're just articulating our vision. So if anyone's got any better ideas, I'm always open to suggestions and really keen to have discussions with people as well. If you're working on this kind of thing yourself. So our goal is to look at developing what we're calling a learning health and social care system. So this notion is not something that's new. It's about being a continuously improving, data-driven, perhaps patient-centered health and care system. And we want to do that to make sure that we're delivering better outcomes for the public, and then making best use of safe, ethical, and effective artificial intelligence. We're doing this by sort of looking at the barriers to entry for the technologies. So we know that access to data is a big barrier. So we're looking at ways in which we can both articulate sort of like a legal, create an environment in which there is a good legal basis, a good legal standing for access to that data, where the needs have been identified, and then sort of like looking at pathway optimization as well. So how do we better articulate our problems as a health and care system so that we're able to actually invite innovations in that meet the needs of people? We've got a big wrapper around that with public engagement. So, if we're looking at access to data and then, user needs, how do we make sure we've engaged the public on that to make sure that they're really involved in the discussions, and that we only scale things that we're ready to, the things that are safe, ethical, and we need to make sure that we've got the appropriate governance frameworks in place there. So, what is the appropriate regulatory system? Has that moved forward? Have we got the appropriate commercial mechanisms? A lot of this work is being done already by Preliminary within the AI lab. So we have an ethics initiative. We've got an initiative that's a national COVID imaging data store, which is looking at sort of like whether or not we can validate AI models at scale. And also we're looking at, sort of model management. How do we provide our local trusts and services with the skills that they need in order to manage multiple models if we get to that? So we're very much looking at sort of like how we might scale these technologies, but we do have a time horizon that is a little bit further ahead than where we are today. So lots and lots of work to be done, and ethical challenges and whatnot to work through. So yeah, we'd love to hear your thoughts. So please get in touch. I'll put some links in the chat, and yeah, if anyone wants to contact us, we'd be glad to hear from you.
Thank you, Lan, so much. Really appreciate it. Continue to look forward to working with our friends across the pond. We know there's a lot of room for collaboration in the future between the US and the UK. Thank you so much. And in the interest of time, I know we're a few minutes behind schedule. We'll probably eat into our break a little. I'm going to turn it over to Jim St. Clair, the Executive Director with the Linux Foundation, who I know has a lot of slides. And I think, just be prepared. We're going to go through them pretty quickly. I believe Jim said he wanted to make sure that all of you have the extra content in the PDF that'll be shared and posted after the event. So with that, Jim, why don't you take it away?
Thank you, my friend, and welcome everyone. Thank you very much for the opportunity today. My name is Jim St. Clair. I'm the Executive Director for Linux Foundation Public Health. I'm going to spend a little time today on what we're doing in the open source world with regards to advancing explainable and ethical AI. Linux Foundation, many of you may be familiar, of course, with Linux as a foundation. We are one of the oldest and largest open source software membership associations with about 400 plus projects, of which Linux Foundation Public Health is focused on open source software, first and foremost for public health authorities, but we're expanding that into other open source digital health applications, of course, to include AI and ML. Next slide. Many of my colleagues so far and preceding me will also talk about, just why AI and ML. And I love the fact that Leanne called out learning health systems. It's a great application. This is an area, of course, many of these areas have been touched upon, and considerations for applications for AI in healthcare, and reasons that we want to consider how AI and ML can improve healthcare. Next slide, please. But I think most importantly, for some of the things we're talking about today is around those challenges and the considerations for how to ensure that AI is ethical, safe, transparent, and usable in a clinical setting. There's challenges around making sure that, the data ocean pollution, that the data being brought into data models for consideration in AI is appropriate, and of course, any malicious efforts to complicate that data. Transparency of the algorithms and challenges around proprietary nature of algorithms. Considerations of patient privacy. Some of you may be familiar with discussions around using HIPAA-based de-identification that can be re-identified through AI and ML, and how we address those concerns. Liability issues concerning commercial clinical applications for AI. And then I think one area that has to be emphasized is cybersecurity. Next slide, please. I'm also part of the Healthcare Sector Coordinating Council, and as co-chair of the Emerging Tech Technical Group. We are working on an AI ML concerns white paper, of which this slide captures the 9 areas we've identified and delineated as specific concerns. Each of us there as specific leads for those concern areas, and then we have supporting subject matter experts for each. Our intent at the HSCC is to publish this white paper towards the end of the month, maybe into February, and be happy to share it with everyone. And we think we're highlighting some of those areas of tech risk that some of my colleagues have highlighted so far, and you'll hear more discussion about today. Next slide, please. In addition to Linux Foundation Public Health and our work in open source digital health tools, we also have an entire project area dedicated to AI and machine learning and a trusted AI committee. That was formed back in October 2019. And in February of last year, we announced the principles for trusted AI, which we'll go over a bit here on the next slide. We've identified 8 data principles for trusted AI. We call it R repeats, and R repeats, and it's repeating the R. Each of those are very similar to these other ethical and compliance frameworks that many of you have probably seen for AI. Built into the EU. I think it's in the Canada InfoWay model. And most importantly, we consider each of these principles to be equal in value, and no one principle has a priority over the others. And of course, they are all very interrelated, especially when you're translating concepts of the underlying IT infrastructure, the algorithms, the data models going into those algorithms, and then their applications for care delivery. Next slide, please. We are focusing in open source development on 3 major categorizations of tools and techniques to help advance these principles for fairness, explainability, and importantly, adversarial robustness. In other words, being able to understand adversarial models that may be trying to maliciously change AI and algorithms and machine learning being used, and then emerging data ops activities in AI and data. Next slide, please. First one I'll highlight is our open source adversarial robustness toolbox. As you can see, it's based around being able to work with all of those various Python libraries for machine learning security, understanding all the tasks and the framework and different data models that may go into those frameworks and how they can be used. And there's a link to the GitHub repository there to be able to see it. Next slide, please. Around adversarial threats to machine learning, 4 major categorizations that we look at as part of the adversarial toolbox: evasion, poisoning, extraction, and inference. Each of those have different ways that they can be maliciously manipulated, and relate back to what that adversarial response toolbox is to provide as a framework for your AI ML language models. Next slide, please. Just to show you the robustness of our contributions, you can see we have over 150,000 downloads, over 8,000 commits, and want to thank all of our participants and adopters and contributors listed on the left-hand slide. And you're welcome to take a look at all these when the slides are available and sign up for them as well. Next slide, please. Next is AI Fairness 360. This is intended to be an open source library toolkit to help detect and remove bias in machine learning models. It translates algorithmic research into the lab and practice. As you can notice there are 70 plus fairness metrics, fairness metric explanations. Of course, as an open source model, always looks for more contributions in terms of explanations or areas to explain and explore, and then 10 plus bias mitigation algorithms to consider as well, with a demo that you can access online. Next slide, please. We also think it's very important that AI needs explainability. It needs to be able to explain its decision. And as highlighted there in a couple of cases, that explainability helps foster trust. In the case of a doctor, why would you recommend this treatment? If you're a customer, why was my loan denied? What is it behind the algorithmic model and the AI and ML being used that explains how it is that decision was reached? And especially in healthcare, when there are specific clinical decision and diagnostic protocols that have to be followed, that need to clearly and transparently be explained in the algorithmic models being used. Next slide, please. As a result, we've developed AI Explainability 360, also an open source library to help explain AI and machine learning models. It is a Python package that includes a comprehensive set of explainers, both at the global and local level. And as I've highlighted, we have global and national participation from companies and contributors. So we're really trying to go for a global, multi-country perspective on various aspects of ethics and explainability for as robust a model as possible. Next slide, please. This is an overall summary, and again, for these slides that will be made available, you're welcome to check out any of these or sign up with the Linux Foundation to be more involved in these projects. Also within Linux Foundation Public Health, we will be developing a specific focus area around AI and ML ethics and transparency and accountability in partnership with the LFAI project, and look forward to working with you there. And I think that's my last slide, Stefan. Yeah. Don't hesitate to contact me if you have any questions, and look forward to talking to you. Thank you very much for the opportunity.
Great, Jim. Thank you so much. A ton of content in a short period of time. Still running about one presentation behind schedule. We'll see if we can make that up with the break and our other presenters. So now I'm going to turn it over to Brian Scarpelli, Senior Global Policy Counsel with the Connected Health Initiative. Brian?
Thank you very much. Thank you. Really appreciate the opportunity to speak here today and offer some of these thoughts. Yes, I'm Brian Scarpelli with the Connected Health Initiative. I guess you can go to the next slide. This is just a little bit of info about us. Not going to spend much time on this, but to give you an idea about who the CHI is and where we're coming from. We are a not-for-profit advocacy organization and policy advocacy organization that our intent is to reflect common threads of agreement from throughout the healthcare ecosystem, from developers to caregivers to the patients receiving care, across a range of issues, and we've been particularly active in the AI space, and I can tell you a little bit more about that and offer some of our thoughts that I hope will build on the great work that you have just heard about from a variety of stakeholders, as well as tee up, I think, some of the specific discussions that are going to follow. Next slide, please. Yeah, this is just something of a mantra for us. We often approach emerging technology issues, digital healthcare policy issues, from the vein of efficacy and support. How is the technology going to actually be supported, and in some cases paid for, and whether it is adequately secure and enabling the appropriate protection of privacy for patients, and et cetera. Next slide. So I think that thematically, just a couple of things to put out there. And again, I hope that, I think we're in alignment here, and this is I'm happy to say something of I can say pretty confidently a reflection of the agreement across all these different very important groups of stakeholders in the healthcare value chain, that there is a shared responsibility for the responsible development and deployment of health AI, and that finger pointing and that sort of thing is I think we've all moved past that, like as a community, all of us here, which is significant and important and worth mentioning. And you can see here that we mentioned some of the stakeholder groups, and there are others that all play a role in working together and collaborating. And I think it's conversations like this and leadership from organizations like ONC and others that you've heard talk that will really help drive that shared responsibility. Ultimately, the quadruple aim, which is building on the triple aim. It's about saving cost and improving population health, and then improving the experience for the patient, absolutely, but also for the care team. All of that really needs to kind of just be infused from the get-go. So our effort has basically been an exercise in trying to pull in as many diverse viewpoints as possible, including government, but also think tanks, industry, large industry, small industry, insurers, and on and on and on. Patients, very important community, of course. And to come up with areas that we're recommending that, certainly policymakers, government policymakers, but also policymakers within an organization think about and consider as they govern their own use of AI and how they're going to enable AI and develop AI. And the recommendations run across a range of areas. I think, just to call out a few, and not going to read all these because I know our time's limited, and I aim to help contribute getting back on schedule there. But I think one concept that maybe is noteworthy here amongst some others, is the idea of thoughtful design. And what I mean by that is that key considerations include, not just about the promise of AI, which we all hear a great deal about, a lot of the hype, but also an acknowledgement of all the challenges that it does arise. And there are unique challenges as well as unique opportunities that we should all think about from the earliest phase of design. And that anyway is an example of one of the concepts that we were able to pull out of the community and put in these recommendations. Others equally as important, bias mitigation and even things like workforce development are worth considering. Next slide. So these are links to the resources that we have pulled together. General policy principles, some recommendations specific to state and policymakers basically overseeing Medicaid and CHIP programs. We at the prompting, something of a prompting from our sector specific regulator for medical devices, the Food and Drug Administration. We really took on the challenge of developing as granular as possible of good machine learning practices that could help with the development and ensuring the responsible development of quality and AI tools what the FDA how the FDA should treat that when those tools meet the definition of a medical device under the Food, Drug and Cosmetic Act. And most recently, and I think that this builds well on some comments made earlier, is we're pulling on new threads and very interested in collaborating with any and all on some of these new specific topics that kind of fall within the areas raised in those general policy principles. The latest one, and I think you've heard this from at least one speaker already, is that unless there is comfort, they're comfortable and willing to trust the tools at the caregiver and the patient level, then they won't be used otherwise. So we've drilled down on that particular topic and offered some recommendations about how to advance transparency, particularly for those two communities and others. And then we're continuing to look at some new areas such as ethics and bias mitigation and things like that. So anyway, these are links to some of those living documents that we're always talking to people about and looking to improve all the time. Here's my contact information if ever helpful to anyone. And again, I think if I would end with anything, it would be a thank you to ONC for their leadership in convening this forum and more generally on AI. I think their role is absolutely crucial, and we're just honored to take part here today. Thank you.
Thank you, Brian, so much. I encourage people to go check out those links. Again, we will be posting these slides, so you can click on the links there. Hopefully some of you took a screenshot of it to use those bit.ly links. But the Connected Health Initiative has put together some great resources for all of you. So with that, next, we'll go to the last presentation of our part one, Guiding Principles section. Greg Nelson, AVP of Analytic Services with Intermountain Healthcare. Greg, why don't you go ahead and take it away?
Yeah, thank you. Thanks for joining. Just to confirm that you can hear me.
Sound great. Can see you as well.
Perfect. So I'm gonna steal a little playbook from baseball, and instead of saying next slide, I'm just gonna pause and nod my head, and hopefully the slide presenter will be able to get my sign, and we'll be able to do this without lots of interruptions. So
sounds good.
We're practicing. Okay. So as many of you talked about, obviously this is a big topic, big issues. In healthcare delivery, we face the monumental challenge of translational science. How do we take all these guidelines and best practices and actually deliver on that promise? And so I'll talk a little bit about what we're trying to do in Intermountain and the progress we've made and where we see the future. So I want to start with first a story. This story is not unlike many patients that you may hear about, even in your own families and in friendly circles. Shakira, a 34-year-old female, presented at urgent care for a skin condition. Physician found that it indicated possible melanoma, wanted to get a dermatology consult ASAP. Physician filled out a referral paper got lost. Patient care was delayed by several months, only to find out that indeed Shakira was diagnosed with metastatic melanoma. These are the realities that we face. When we think about Shakira's journey, so we should be looking at the slide that says Shakira's referral journey map. You know, we see lots of positives and negatives during that journey. And one of the challenges that we often face in analytics is where do we apply AI? And so I think one of the frustrating parts for me, go ahead and go to the next slide, is that what we often see from the vendor community is vendors that are targeting specific opportunities. They want to do chatbots, or they want to do e-consult reminders, or pre-authorization algorithms. And in healthcare, what we're trying to do is tackle this symphony. You know, in this example, you know, we're really talking about a cacophony of opportunities that all have to be stitched together to create positive experiences, not only for Shakira, but for our providers. You know, when we think about next generation systems, go to the next slide. I love this quote from Chris Ross, you know, where he says, next ought to be a system of intention, insight, and cognition, systems that automatically know what we want, help us see what we wouldn't otherwise see, and help us think. I'll talk a little bit about some of the bias detection algorithms we have, as well as equity detection in our system. And, you know, the opportunity landscape just in acute care is massive. If I look at this list of potential opportunities, you know, there's everything from left without being seen algorithms to you know, high cost or length of stay predictions. One of the quotes I like to talk about when we talk about this symphony or tapestry is from John Fremont, who's the chief strategy officer at Hypergiant, and he says there's no one thing that defines AI. It's more like a tapestry of modern intelligent technologies knit together in a strategic fashion that can uplift and create knowledge base that's automated. Our chief health information officer talks about responsible AI applications that automate routine tasks and create time for providers and caregivers to listen and see and feel what patients are sharing and need. And AI, quite frankly, presents providers with data-driven insights, next best actions, and suggested evidence-based care plans, treatments, and interventions for patients. You know, and we talk a lot about AI is not trying to take our job or do things for us automatically. It's really about improving that cognition, help us to see what we wouldn't otherwise see. So in design thinking, we use a lot of human-centered design in our product development. You know, we often will get asked the question, well, what's true? And we flip that question a little bit in design thinking to talk about what would have to be true. So responsible AI might mean different things to different audiences. I've heard you talk a little bit about the patient, the community, the provider, and the caregiver. You know, for the patient, responsible AI means that it's proven and that it respects their privacy. For our community, it's fair and ethical. For the provider, it's trustworthy and they're involved. And for a caregiver, it's transparent and validated. So we've developed an AI responsible framework and an AI playbook to talk about how do we actually use AI responsibly. And we think about it in terms of the act of making sure we always couple AI solutions with these key values in order to identify and avoid unintended consequences. Someone mentioned that earlier, is that, you know, algorithmic bias or unintentional consequences are often not based on the bad behaviors or ill intent, right? It's about, you know, we did something because it was cool. And I often teach, you know, graduate students this idea of just because you can doesn't mean you should. So our AI playbook is really about a commitment or a promise to how do we use advanced analytics and AI and machine learning to help improve healthcare responsibly. And I'll talk a little bit about where that fits in our organization, but it's really about adopting some of the principles that we've learned. I heard somebody talk about life sciences or the FDA, the software as a device. We really want to make sure that we are operating in the good software development best practices, good manufacturing best practices, and view AI in that same vein. So you often may hear about service level agreements. We talk a lot about experience level agreements, and our experience level agreement to our caregivers and our providers and our patients and our community is about here's our commitments. We're going to make sure that we do the right things. Oftentimes AI, at least in the early days, were science experiments. We want to make sure they're aligned to the problems that we need to solve. And I love how Leanne, I think I'm saying that right, Leanne, from the National Health Services, how do we articulate the problem? We teach a class at Intermountain called Decision Intelligence, where we actually teach people how to frame problems. It's a really important skill set that we get really, really good at. But once we have the problem defined, is how do we actually co-create? We have a patient advisory board, for example. We have a caregiver advisory board. We have an ethics committee, but we want to make sure that we do this co-creation with that in mind. Certainly model validation. Many people talk about diversity. We actually have a Design for Diversity initiative where every model goes through a diversity algorithm bias detection process and is continually monitored for bias in the model. Of course, we publish everything in our AI catalog and model card so that everyone has the chance to see what is this thing trying to do, how was it tested, what was the actual test data that was used, what was the bias detection algorithm's assessment of that underlying data, and of course, overall long-term with model drift and to make sure that we're not making mistakes long-term. So the AI playbook is just one of those parts. We launched the Data Science and AI Center of Excellence, really about, people talk about community of practice, they talk about Center of Excellence or Center of Enablement. There are a number of things that we're doing. People have talked about AI literacy, some of our toolkits that we've developed. One of the things that we want to lean towards is action. Every chance we get with a patient is a chance to delight or it's a chance to frustrate. And we want to delight our caregivers and our patients and our communities at every interaction. And we feel like there's a zero harm opportunity here that we need to just make sure we continue to focus on. How do we not get it wrong? The risks of getting it wrong are way too high. So we've outlined a very clear process. I often hear, well, is this the think tank? Is this just documentation for documentation's sake? And we often will present a slide. This is not think tank, this is do tank. And so these are our processes for everything that describes how we consider the feasibility or viability of a new product or AI algorithm. And starting in the upper left-hand corner is, does it meet some of the strategic alignment areas? Is it feasible? Just because you can doesn't mean you should. And then during model development, we've put in guardrails for making sure that we're doing our baseline assessments of bias detection and so on, and piloting things. Is it driving the right behavior? Is it driving the right outcome? Or is it simply interruptive in their process? And of course, during deployments and sustainment is monitoring key metrics and results and the outcomes. And just like anything, we need to plan for retirement. And so how do we actually build that into our process? So this strategy is really going across as we think about vended solutions. I know there are a lot of vendors out there developing algorithms and point solutions that solve specific problems. We think about those as just another piece of the tapestry in our overall strategy. We do have a lot of in-house developed algorithms. And part of that is to continue to provide challenger models to those that might be vended or through external collaborations or marketplaces. If we simply blindly accept black box algorithms, then we're eventually going to get tripped up. And so we want to make sure we're always shining a light on the opportunities. So I'm happy to share. Here's my contact information. If people want to double click on anything that we've talked about, happy to share. And thanks for having us today.
Thank you so much, Greg. Really appreciate the great work that you and Intermountain is doing on this and being so transparent with sharing all of that with us. So I hope people do follow up with you to learn more. We are a little behind schedule. So unfortunately, we're going to forego our break and just dive right into our next part of the showcase. Wanted to remind folks as well to use the Twitter hashtag HealthIT_AI and tag the ONC Twitter handle that you see here as well to continue the conversation on Twitter. And with that, hopefully we've got our part 2 lead presenter, Devin Willis, with the Federal Trade Commission. Devin is an attorney in the Division of Privacy and Identity Protection. If you're on, go ahead and turn on your camera and unmute and take it away.
Can you hear me?
Yes, go ahead.
All right. Well, thank you, Stefan, for having me here today, and good afternoon, everyone. I've really appreciated hearing all the great work that you're all doing to help ensure that innovative health AI technologies are transparent and fair, and I look forward to the upcoming presentations today. Before I start, I just need to note that the views expressed in this presentation are my own views and not necessarily the views of the Commission or any individual commissioner. Now, while there are a range of benefits to using AI in health technologies, my goal today is to quickly share how the Federal Trade Commission has been helping guide developers and users in making sure that these technologies are developed and deployed in a transparent and fair way, and in accordance with the Federal Trade Commission Act. So next slide, please. All right, thank you. So for those of you who might be less familiar, I just wanted to give a little background on the FTC Act. So Section 5 of the FTC Act determines a trade practice to be unlawful if it is deceptive or unfair. The technical definition of deception is a material representation, omission, or practice that is likely to mislead a reasonable consumer. So essentially, it's unlawful to make claims that are false or not supported by evidence, and it's also unlawful not to disclose information that might be useful to a consumer's purchasing decision. The law defines consumers in a broad sense, meaning that claims made, for example, by a developer of a health technology to a business or other entity that might use that product could be actionable. In addition, it's important to stress that a business that simply relies on a developer's deceptive claims by failing to adequately vet the claims itself before passing them on to consumers also could be held responsible under the law. A practice is deemed unfair if it is likely to cause substantial consumer injury and the injury is not reasonably avoidable by consumers and isn't outweighed by benefits to consumers or competition. So now I want to try to unpack these principles with examples to recent FTC cases and guidance in, I guess, about the 5 minutes I have to try to get us back on schedule. Just to note that some of the cases may not be specific to health AI, but I think they're very relevant to transparency and accountability in the development and use of health AI. So we've encouraged developers or users of AI and health IT to avoid being deceptive by being transparent. You know, we've said that they should avoid making claims that a health technology or its AI or algorithm can diagnose or mitigate harm from illness or other significant health conditions unless the claims are supported by competent and reliable scientific evidence. For example, the FTC has brought actions against marketers of apps that deceptively claimed without scientific evidence to be able to assess cancer risk by using image risk analysis algorithms of uploaded mole photos. Similarly, we've reminded not to overpromise a technology's ability to reduce bias or improve decision-making, or to make claims that a technology isn't biased without evidence. We've brought cases to stress the importance that companies live up to their promises about how consumers' personal information will be safeguarded. Most recently, the FTC settled a case involving an app using AI to provide an ovulation calendar, period tracker, and pregnancy guide for users. The app's marketers repeatedly promised that intimate details about users' reproductive health would be protected, kept secret, and not shared with anyone. But the company shared users' health information with Google and its marketing service, Facebook through its Facebook analytics tool, and other marketing and analytics firms. And the app developer didn't take measures to limit what these companies could do with users' information. Rather, it simply agreed to the standard terms of service. This gave the firms the ability to use the information rather expansively, including for targeted advertising. Our Everalbum and Facebook cases there stress the importance of not misleading consumers about the power they have to control or limit access to their data. In both cases, the companies suggested that facial recognition wouldn't be used, but by default it was on, and data collected from consumers were used to train other machine learning models. An important thing that we stress about these orders is that companies were here required to delete the ill-gotten data in addition to models and algorithms using the data. We've also reminded companies to be truthful and transparent about the use of automated tools and why consumers' data are collected or used. CompuService is a good example of what not to do. Unbeknownst to consumers, this credit card marketer had used behavioral scoring models to assess and sometimes reduce the amount of credit that it marketed would be available to consumers. The FTC alleged that failing to disclose to the users that data about their purchases would be monitored and inputted into this model was misleading. Can we go to the next slide, please? The FTC has also stressed the importance that developers and users of health technologies make sure their technologies are developed and deployed fairly. The biggest tip that we've stressed in guidance is to be accountable and responsible for ensuring that the development or use of AI is fair. More specifically, that it provides more benefit to consumers and competition than harm. We stress the importance of taking reasonable steps to protect the privacy and security of sensitive personal information, including sensitive health information. Companies should have written policies and measures in place to safeguard consumers' personal information and protect them from potential harm caused by unauthorized persons accessing their information. For example, we had our SkyMed case, and we've told people don't be like SkyMed, where the FTC challenged that it failed to employ reasonable measures to secure users' health and other personal information in a way that left unsecured a database containing 130,000 user records with personal information stored in plain text. We've also stressed in guidance that both developers and users of health technologies should establish procedures to evaluate potential unintended harms that the use of health AI and technologies could cause. Because as we all know and has been discussed earlier, even good intentions can sometimes result in negative outcomes. Each year, the FTC's Division of Privacy and Identity Protection hosts a conference to discuss the latest research and trends related to consumer privacy, data security, and AI. The last two conferences highlighted research on health AI and machine learning. Research revealed what was thought to be neutral algorithms designed to direct healthcare resources to those who need it most inadvertently produced very harmful outcomes, funneling healthcare to white patients to the detriment of sicker Black patients. When you have time, I recommend that you look at the Algorithmic Bias Playbook shared at last year's PrivacyCon, which provided steps that companies using health technologies can take to detect and mitigate bias. It's available on our website, and I can send it around if people need it. These steps that were highlighted are very similar to steps highlighted by staff on ways to harness the benefits of AI without inadvertently introducing unfair outcomes. Some steps that we have suggested companies can take to identify and remedy potential harms include things that I'm sure you're all familiar with: double checking that data sets are representative, looking for gaps, see if traditionally underrepresented groups are represented. Also, we've encouraged people to look out for any unintended impacts, perhaps due to historic biases. For example, the healthcare algorithm discussed at the PrivacyCon used data about patients' healthcare spending as a proxy for healthcare need. However, developers didn't consider the systemic racial inequalities in healthcare access that tainted these data. We've also stressed the importance of having human oversight to identify biases that aren't initially obvious. And importantly, we've suggested that companies be transparent with data and algorithms and consider using independent third-party testing tools, standards, or auditors to test technologies before and during deployment. It was actually independent researchers who spotted the racial biases in the healthcare algorithm that was described at our PrivacyCon by examining data that was made transparent by a large academic hospital. The FTC continues to keep an eye on the market to make sure companies are developing and deploying emerging technologies, incorporating health in addition to other AI in a truthful and fair manner. And we're very excited, to be part of discussions like these today to help advance responsible AI. So hopefully I was able to rush through that and save us some time. Thank you again for your time and attention.
Devin, thank you so much. I saw a couple comments in the chat about how they wish this was a full day long presentation from you because it's amazing content. We're all grateful to know the FTC is helping look out for us over here in the healthcare sector as well, and applying those same transparency type of requirements. So really appreciate it. Thank you so much. Next, I'm going to turn it over to, again, one of our great colleagues we work closely with at the FDA. We've got Aubrey Schick, who's a digital health specialist with the Digital Health Center for Excellence. Aubrey?
Thank you, Stephen, for that introduction. And with that, to speed things up, go ahead and advance to the next slide. So as we know, we're talking specifically about transparency, and in this case, for artificial intelligence and machine learning enabled medical devices. You know, the first thing I want to talk about is in January of 2021, we published our action plan for AI/ML based software as a medical device. And this plan outlines a holistic approach based on total product lifecycle oversight to further the potential that these technologies have to improve patient care while delivering safe and effective software functionality that improves the quality of care that patients receive. So that plan lays out 5 actions, including further developing the proposed regulatory framework, including the issuance of draft guidance on predetermined change control plans for software that learns over time, supporting the development of good machine learning practices to evaluate and improve machine learning algorithms, and fostering a patient-centered approach, including device transparency to users, which I'll be talking a bit more on, developing methods to evaluate and improve these machine learning algorithms, and advancing real-world performance monitoring pilots in coordination with stakeholders and other programs. Next slide. So this is a quick overview of the collaborative approach that we've been taking toward enhancing transparency of AI/ML enabled devices. So throughout this process, we've been engaging stakeholders through ongoing discussions, public workshops, and public docket comments to guide our next steps. This approach includes our AI/ML discussion paper, collaborative communities, our public workshop on AI/ML and radiological imaging, engaging our patient engagement advisory committee, and all of these efforts informed our AI/ML medical device software action plan. We also posted a list of currently marketed AI/ML devices. We held our public workshop specifically on the and more recently, we published our Good Machine Learning Guiding Principles document. Later today, you're going to hear from my colleague, Sean Forrest, who will be providing more detail on our action plan and Good Machine Learning Guiding Principles. Next slide, please. So in October at our transparency workshop, which included patients, providers, payers, researchers, and industry, we recognized how these AI/ML devices can continue to have a significant positive impact on healthcare. And I think we talked a lot about those opportunities today. And we also recognize the challenges that also include the fact that, large, well-curated data sets that are necessary for devices development and testing can also be difficult to obtain, especially ones that reflect the diversity of the intended patient population. We also recognize the challenge of including the identification and minimization of bias and the opacity of some of these algorithms. There's a challenge in providing more continuous oversight for an adapting system, and importantly, for ensuring transparency to users of these devices. Next slide, please. So our workshop focused on the fundamental nature of transparency to a patient-centered approach. We recognize that transparency allows patients, providers, and caregivers to make more informed decisions. To build on that, transparency supports the proper use of a device. For example, it's crucial for users of these devices to understand whether or not the device is intended to assist rather than replace the judgment of the user. Transparency also has an important role in promoting health equity, because, for example, if you don't understand how a device works, it might be harder to identify the bias. And it also facilitates the evaluation monitoring of device performance. After all, it's important to know how well a device is supposed to work in order to identify that it may not be working well. And of course, transparency fosters trust and confidence. And without that, these devices are not going to be fully utilized, which is all to say that again, transparency is fundamental to a patient-centered approach and supporting the safe and effective use of these devices. Next slide, please. So through these discussions, we really focused on the specific needs of our stakeholders, what information is appropriate to communicate, and when. The best way to communicate that information to different stakeholders. And even more specifically, how can device labeling be improved? How can other public-facing information be improved? And what else can we be doing to support transparency? So at this time, we are carefully considering all of the discussions held in our public workshop, as well as the comments from the public docket to inform our next steps toward informing transparency. Thank you.
Thank you, Aubrey, so much for the presentation. And I'm glad you got to highlight the workshop that you hosted at the end of last year. For those who missed that workshop, I highly encourage you to go back and look at all the follow-up from it and view any recordings as you might be able to. It was an outstanding event. And I think that although it was focused on software as a medical device and medical devices in a lot of cases, many of those principles and practice and guidance can be applicable in other scenarios as well. Next, we have up our good colleague, Chris Dymick with AHRQ again. Go ahead and take it away, Chris.
Thanks, Stefan. I'm really glad to be here today to share some thoughts about responsible AI with everyone. Next slide. So first of all, regarding the ARC division that I represent, we were formerly known as the Health IT division, and our new name reflects the fact that the digital healthcare ecosystem has recently exploded beyond traditional health IT, such as electronic health records, and we want to capture that expansion. The graphic on the left of this slide denotes many of the elements of that expanded digital healthcare ecosystem. And our mission is to determine how the parts of that ecosystem can best come together to positively affect the quality and safety of healthcare. Our job at ARC is to produce evidence, as my colleague Craig Umscheid mentioned during the last session. My division's mission reflects that. We do our job primarily by funding research conducted via extramural grants and contracts. I also want to mention our vision, which is that every patient and care team will have ready access to all applicable data and knowledge mediated by advanced analytics, including AI, to address a patient's health and healthcare. We're after ultimate data and knowledge liquidity at the point of care, but we'll need AI to appropriately process the sheer volume of data and digitized knowledge. This is important because we believe that data, advanced analytics, and computable knowledge are foundational and are going to power high-value future care modalities. I also provided a link here to our website and recent annual report if you'd like more info about the work overall that we're doing. Our annual report contains more information about the 2 AI research exemplars that I'm about to share with you, as well as other research we're engaged in. The 2 key points that I'd like to drive home today are that first, we need to take AI algorithms into healthcare settings and rigorously test and evaluate them to ensure that the algorithms are doing what they're supposed to be doing. That's the simple but important key to creating responsible, trustworthy AI. You can start with what you think are great training data, but you can't be sure your AI algorithm is doing what's intended until you've actually tested and evaluated it in real-world healthcare settings. And even then, you need to be clear about the limitations of your study for those who may want to use the algorithm in additional settings. Secondly, we need to better understand how we can best achieve human-machine teaming in healthcare, like it's been understood in fields like aviation. How can we integrate AI into actual healthcare workflows to maximally affect achieving better health outcomes? My first research exemplar is a great illustration of these points. Next slide. So this is a recently completed feasibility study by Dr. Michael Avedon and a team of researchers and computer scientists at Washington University who applied data mining and machine learning to develop predictive algorithms, helping to predict patients who are at risk for specific complications during surgery. This team then used the predictive algorithms within an intraoperative telemedicine intervention that they called the Anesthesia Control Tower, or ACT, to help enable ACT clinicians to spend a greater proportion of their time actively monitoring patients who are at the highest risk for post-operative adverse outcomes. Increasing the proportion of their time actively monitoring patients who are at highest risk helps them actually then pay attention to mitigate risk for the patients in the OR and communicate those risks to the operating room anesthesiologists. This research team established the feasibility of the ACT concept and provided the necessary foundation for a 5-year large-scale study to further investigate the effect of the Act on post-operative clinical outcomes. Next slide. As most of you know, emergency departments deliver high-volume patient care in hazardous decision-making environments with excessive cognitive loading and time pressure. AI has the potential to support ED clinician decisions by using large-scale electronic health record data to aid prognosis, extract signal from noise, and reduce variability in practice. Despite AI's promotion, translation to practice is rare, and means to incorporate AI that's trustworthy, transparent, and explainable in the ED are largely unknown. This large-scale R01 study, noted on this slide, will be covering the full spectrum of developing, deploying, and evaluating an AI-based clinical decision support tool that promotes improved management and prevention of kidney disease. This Hopkins-based research team has a specific aim to conduct live usability testing of their tool. Their evaluation will also assess the impact of the CDS on both process and outcome measures. I really like this study because it's going to create new knowledge and best practices for incorporating AI in unique ED settings. It's a great example of research which sets out to validate that, first of all, the AI intended or does what it's intended to do, and that it's actually usable by clinicians. And most importantly, that it can have an impact on health outcomes. It's the type of AI research that we're interested in funding at ARC. So thank you for allowing me to share this research examples and from our portfolio, and my contact info is on the next slide. Thanks again.
Chris, thank you so much for all the work you do every day and for collaborating with ONC over and over again. Again, also for co-authoring that blog post on the Jason's report from back in 2017. So we really appreciate all your contributions in this area and continue to look forward to working together with you. Next up, we've got Jay Vietas with the Centers for Disease Control, specifically in the National Institute for Occupational Safety and Health, or more commonly known as NIOSH. Jay serves as the Chief Emerging Technologies Branch. Jay, why don't you go ahead and take it away?
Hey, thanks so much. I appreciate being part of the discussion today. We're going to talk a little bit about occupational safety and health and its relation to AI. Next slide, please. So just a primer on NIOSH. If you haven't heard of us, we are an agency responsible for conducting research and making recommendations regarding the prevention of work-related injuries and illnesses. Our sister agency, the Occupational Safety and Health Administration, is more interested in sort of the regulatory and compliance-based piece of it. We're more focused on the mission of developing new knowledge and transferring that knowledge into practice at discipline of translational research. Next slide, please. So I want to orient you today to work being a social determinant of health, and that the average working American spends half their waking time at work, and so it's a significant determinant of health outcomes and certainly should be attended to appropriately. The Bureau of Labor Statistics reports the annual injuries and illnesses, and sort of pre-pandemic, the 2.7 million injuries and illnesses per year occur in the workplace. So it's not a trivial number. But interestingly enough, work rarely guides the clinical decision-making with respect to how we take care of these occupational injuries and illnesses. And oftentimes this is really a function of the work information being both incomplete as well as inconsistent to help provider and provider teams to do so. Next slide, please. And so just to orient folks, there's a fair amount of worker data that exists out there. Some of the basics include certainly industry, job type, length of employment, but there's a whole host of information that exists within occupational medical exams, some of which is included in the electronic health record already. Some of that's proactive monitoring regarding the type of job that they do, and some of it's just reactive in terms of maybe disaster response or some sort of incident that occurs that demands some sort of medical exam. But interestingly, the medical outcome piece, I think, is also an area of value. This population is one that's going to be monitored to see what happens long-term in terms of whether they come back to work completely or maybe are on light duty for a fair amount of time, or may self-select and not continue to be employed. Those are all real good markers towards clinical decision-making and ultimately the effectiveness of those clinical decisions. Of course, there's data with respect to compensation claims, such as worker compensation databases that have information out there that can be valuable, although certainly it's self-serving in terms of its purpose. And then the advantages of improved computer power and sensor development really are allowing for an explosion of exposure monitoring in the workplace, whether that's simple physiological monitoring, some additional biological monitoring, or just external, traditional air sampling that can occur and tell a lot about what the exposures are to the workers that can help, again, categorize the risk associated with workers in their particular job and job types. Next slide, please. And so all this, gets to the thought process of what's the real benefit of placing some of that work information into or next to the electronic health record. And the Institute of Medicine and a variety of reports that they've provided really show that there's improved care, whether it's quality, safety, efficiency, or coordination of that care, ultimately improved treatments. And if you combine those two, you should see an increasing amount of return to work along the way. And of course, one of those areas that we continue to be, along with many of the other partners at this point in time, interested in health equity. If you were able to pull this together, the IOM suggests that we can reduce health disparities that exist out there as well. And NIOSH has put together a product that can help with an initiative called the Occupational Data for Health. And it has tips, and the document that I've listed below has tips for where we can actually improve that relationship with the health IT system. Next slide. But the challenge obviously is, even though it's great to think about the data that we need long-term, systemically, there are some hurdles that we must cross to get there. Some of that's employer, employee, insurance company, and certainly the provider teams. How do we make sure that from a time and efficacy standpoint that we can do this? Part of it is focusing on interoperability between the databases that already exist, but also to ensure adequate collection of the data that exists. Of course, we have to attend to data privacy and security and meet the various regulatory requirements, which is kind of driven by all these other needs up above. Next slide. So what are we doing at NIOSH? And so with respect to artificial intelligence at this point in time, we're doing a number of things, but when it comes to the electronic databases that we have, one of the things that we're doing is using AI to improve the quality and reliability of the data that we collect or that we have access to. So for example, with respect to worker compensation claims, for about 10 years now, we've been ensuring improved assignment of standard federal job codes as a result of using the narrative that we're provided and turning this into, again, classification of the various jobs that folks do. And then we've been able to develop a product called the NIOSH Industry and Occupational Computerized Coding System, which has been shown to provide standardized occupational coding for databases such as the behavioral risk factor surveillance system information that we retrieve. So really important to take this natural language processing and turning it into valuable outputs for additional study. But the future is really bright if we are to harness all the data that's out there with respect to understanding the long-term development of chronic disease and risk development, to improve the understanding of the relationship between work and mental health. Obviously, this is a societal concern that could be enhanced through the use of artificial intelligence and ultimately together improve the definition of healthy workplace. Look forward to any future discussion with others and appreciate this quick discussion today. Thank you so much.
Jay, thank you so much to you and your colleagues at NIOSH. So many times people think about healthcare only in the context of clinical settings, and it's important to remember the communities we live and work in, and certainly the workplaces play a big role as well. And especially with the return to workplace, considerations that people are making in the time of COVID, I'm sure that your work is going to be even further, elevated and considered more important to look at. All right, next we're going to move to. We're very lucky and fortunate. We've got Jack Resnick Dr. Resnick is the president-elect with the American Medical Association. And Jack, if you would unmute and turn on your camera, please take it away.
Great. Thank you so much for having me. And thanks to ONC for bringing together so many stakeholders today. I've really enjoyed all the talks thus far. It's just fantastic to see such growing alignment on so many issues related to quality and to transparency of AI. Let's jump to the next slide. So it's become pretty clear that physicians are likely to face hundreds of choices of AI tools for any given clinical purpose. And as I talk to colleagues around the country, they're very excited about the potential, but they want to choose and want to deploy tools that are going to actually advance health for our patients. So with AI, we basically are asking a series of questions with any given tool, similar to what we would ask about any innovation. Most importantly, does it work? Just as we do for drugs or biologics, we want to see clinical evidence of efficacy and clinical evidence of safety so that we can weigh risks and benefits. We also ask who's accountable. The less transparency we have about a tool, the less well we can counsel patients about the risks and benefits, and the less responsibility we can really take as a physician if there are bad outcomes or if there's a data breach. And last, but really importantly, each physician and each practice is asking, is this tool going to work in my practice? And I really think about this in a couple of different buckets. One is applicability and the other one's value. On the applicability front, we're thinking, was it deployed and tested in a venue like mine on patients like mine? Because we see examples where a tool that works really well in one setting is brittle and ends up failing when implemented in another setting. There's recently published study of a really well-intentioned sepsis prediction model. It was made by a large EHR vendor and trained at 3 large hospitals where it performed pretty well, but when it was independently studied at another large health system, it only picked up 7% of missed sepsis patients. It failed to identify 67% of those with sepsis, and it generated distracting alerts on 18% of all hospitalized patients. The second bucket I mentioned is value. This is really, does the tool address something important? Does it address a real need or a gap in care? There are tools out there that sound really cool, but just don't fix a meaningful problem or improve health outcomes. I was glad to hear Greg from Intermountain allude to this earlier with his sort of not everything that can be built should be built analogy. And also under value, does it advance health equity? Again, glad to hear this discussed by so many fellow presenters today, and I'm going to return to this in a minute. Next slide. So the AMA actually convened experts from multiple specialties to gather feedback, and we heard loud and clear that AI, when done right, has tremendous potential to improve health outcomes. And we heard enthusiasm about disruptive innovation that's clinically validated. Where we heard concerns, it was mostly around lack of transparency that would interfere with trust. Next slide. What physicians and patients are craving is clinical validation. Just as we want to know the risks and benefits with a new drug, we like to see published peer-reviewed data for that trust development. That, of course, includes efficacy and safety, but also the characteristics of environments where, and of the patients and the location where it was tested. This is not new. When you think about randomized trials for drugs, we sort of expect that table in every study that shows the demographics and details of the treatment group and the control group in drug trials. We can do this with AI too. Another part of transparency is explainability. I was glad to hear Jim from Linux and Karen from Canada bring this up earlier. We know that AI can't always explain why it learns certain things from a training set. And this opaque box is a challenge to trust development. But the tools that can state what things about a current patient's data are the primary drivers of a recommendation are going to be more trusted than those that can't. The level of transparency and explainability that we need, we think, is also related to the risk level of an individual tool. Is a tool being used for clinical decision-making versus administrative purposes? Is it using a locked algorithm or is it using a continuous learning system? Is it being developed for a local bespoke use or is it being commercialized broadly? Transparency is also really important to prevent biases that we know can exacerbate rather than ameliorate disparities. We've already seen too many examples out there of systems that are found to have biased training data or just a failure to imagine on the front end other design flaws. And this can really lead to systems that unfortunately invisibly and unintentionally reproduce and normalize the racial and other biases of their training sets. Part of what drives the need for transparency is that these risks aren't always evident from initial trials of an AI tool, and we've heard about this from some other speakers today. It was abundantly clear, for example, with the recent example that Devin Willis from FTC highlighted, where a large health plan had deployed an algorithm on millions of patients to identify those with high risk of disease exacerbations in the coming year. The intentions were good, to redirect more resources to help those patients. And the evidence showed it worked and found some patients who needed more care to avoid exacerbations. But it learned by looking at resource use as a proxy for health needs. We already have inequities in healthcare, so it learned those biases. And so basically at the end of the day, putting in the same patient with a different race, it directed resources and early interventions to a white patient rather than a Black patient with the same health conditions. We've got to intentionally apply an equity lens upfront from the beginning at the development stages. Are we including diverse patients in the machine learning, in the testing? Are we deploying to diverse communities? Are we testing for biases in the code? I've seen something kind of similar, not on the equity front, but just in terms of bias training sets that get discovered later in my own specialty of dermatology, where a melanoma tool that was designed to assess the need for a biopsy of a mole on a patient showed pretty good sensitivity and specificity in trials, but it was later realized that cancers in the training set mostly were preoperative lesions, where a surgeon had actually drawn with a marker around the lesion to mark the spot where they were going to do the surgery, whereas the benign lesions didn't have those markers. And it basically led to a situation where you could bias the tool by whether or not you drew a circle around the lesion. So we've got to intentionally hypothesis test up front and look for these biases. Next slide. Transparency really needs to extend to AI product labeling as well. And we're encouraging the FDA and other stakeholders to think about and develop lists of required disclosures. This clearly includes safety data, efficacy data, the populations, as I mentioned earlier, on which a product is validated, but also the limitations of the data sets that were used, also privacy risks. We also think post-market surveillance is key. As I said earlier, people often figure out AI biases well after deployment. Last slide, please. I really appreciate the opportunity to be a part of today's session. Physicians are tremendously excited about the potential of AI, but we really think that thoughtful design at the front end, including the use of an equity lens, clinical validation, appropriate transparency, and appropriate regulation where the risks demand it, are going to build more trust with end users. And those end users include us as physicians and absolutely include our patients as well. Thanks again for the opportunity to be here, and I'm looking forward to the rest of the talks and the panel today. Thanks.
Jack, thank you so much. We appreciate all the great work that you and the AMA is doing on behalf of physicians and working closely with them. And we're excited to hear that your voice and the physicians' voices are echoing many of the same concerns and sentiments you're hearing from all the other stakeholders. So truly appreciate it. Next, we're going to go ahead and move on to our good friends with the Duke Margolis Center for Health Policy, who also hosted an event similar to ours with some of the same speakers earlier or towards the end of last year, and really want to thank them for all the work that they're doing. So I'm going to turn it over now to Christina Silcox, a Digital Health Policy Fellow, who will talk about building equitable and trustworthy AI.
Thank you so
Christina?
much. Can everyone hear me?
Coming through clear.
Okay, great. So first, just want to thank ONC for inviting me to speak, and everyone for joining this meeting. It's been fascinating so far, and I'm hoping people won't be too bored in their presentation because I am going to be repeating some of the points that we already heard. Next slide. So first, I always like to show this slide, which is from a USAID paper from a couple of years ago, which really does a great job of saying that when we say AI in health, this is an enormous space. And that can include population health software, that can include individual health software, health system software, pharmaceutical software, software to help pharmaceutical and medical technology companies develop new products. So really an enormous breadth. And while most of our work has really focused in the clinical decision support space, both for population health and for individual health, I think it's really important to take a step back and think about when we say trustworthy and equitable, that may mean in the specifics different things for different types of use cases. Next slide. So we have been working in this space for a couple of years, and we put out several papers that I encourage everyone to take a look at. The ones I'm going to be talking about today are 2 papers that we wrote around information flow around AI-enabled software, as well as a upcoming paper that we're going to be putting out around understanding bias and fairness in AI-enabled healthcare software. That's where that public meeting that Stefan referenced when he was introducing me came from, and you can find a link to that to that meeting on this link at the bottom of the screen here as well. Next slide. So first, I want to talk about information flow and what do stakeholders really want to know when with AI-enabled software. And we did some research around this, and we really found a couple of major questions that came up over and over again. And the first is, how does this AI software fit into my clinical workflow? Is it giving me an answer that I'm interested in? And is it giving it to me at a time in which it's useful? And is it giving to me, the right person, as opposed to someone else, the wrong person? Next is, what type of AI does this software use? And so is it a machine? Is it a rules-based algorithm that's built on clinical guidelines? Is it a machine learning algorithm? Just how did this software, where did this software come from? And then how was this AI software built? And often what that means is, was it built using best practices? Was the training data representative? How was this AI software tested? And then how does this particular AI software work? And this is where we get into explainability. And the answer can be, we don't know. And in some cases, we found that stakeholders were okay with that, given enough performance data. And this is where a risk-based analysis really comes into play. So what does your software do? How risky is it? Is an explanation needed? Or is performance data enough? And I think that this is an ongoing question that really does depend on the risk of the software. And also, just as our trust and experience with AI continues, we'll continue to determine how explainable a software is, whether that's acceptable or not. Finally, how much should this particular recommendation be trusted? And this is something that stakeholders told us over and over again was really important to them. Even if the software works well generally, is a specific recommendation something that I should trust? Or is my patient someone who looks pretty different from the average patient that this software has been trained on? Is this on a borderline recommendation? Is it close to kind of that line where the software would have gone to a different recommendation? And so people are really interested in that as well. Next slide. So when we talk about trustworthy AI, I do want to talk about, why are we worried about that? And why people have concerns about AI being trustworthy versus other types of medical devices that we may have. What's different about AI? And here we want to talk about the idea, well, it's new. It's new software. We don't, or at least people's perception is new. I will say that AI has been around for a long time, but the perception is it's really new. And it is becoming more complex. So I think that's still a fair assessment. And so people just don't have that base experience with these devices to know whether they should trust it or not. Also, AI is built on health data, and health data is heterogeneous, complex, fast changing, of variable quality. Oftentimes when doctors find out that AI has been built on EHR data, they say EHR data. My experience with EHR data is it's often wrong. And so why should I trust this? I think that this is really important. The fact that health data is also fast changing is really important. So this AI worked on health data from last month, but is it going to work on health data now? We may have new medications, we may have new treatments, we may have new workflows. Does this AI still work? Because our health data has changed. You often have less information about how the product was made and how it works, that explainability issue that has been talked about several times. And so not only do I not know how it works, which is actually not necessarily an uncommon issue with medical devices and in a hospital, somebody using that device may not know how it works, but nobody knows how it works. And that's a really important distinction. When you have a medical device that you don't personally know how it works, but experts do, then when it goes through FDA and through other reviews, then the people who do understand where it is, know how it works, know where the risks are, and know how to test for those risks. When there's no information about how it works, it's much harder to know how to test for risks and how to know when it's not going to work, as was brought up earlier. We also often have faster update cycles with AI that will go up to continuous AI, which is not existed really in the health space right now. But eventually, if we have continuous AI software put into place, then the software that you use right now was different from the software that you used this morning. There's also a lot of privacy issues around using health data and where is that health data going and how is that potentially being used once it's left, if it's left a space, the healthcare space. And then also concerns about bias. Next slide. So we are in the middle of some work around how AI becomes biased or unfair, and I want to move quickly. There's a lot of different ways that AI can become unbiased or unfair. And when I say biased, what I really mean here is that it doesn't work for a particular subpopulation as well as it does for other subpopulations. And that can happen in a couple of different ways. Really, these middle three circles of representative, you have unrepresentative training data, you have bias within the training data. So even though your data is representative, the bias itself, the data itself has bias. We heard about that in the last presentation. And you've made curation and training optimization choices that bias the data in one direction or another. And there are beginning to be emerging best practices and tests for this. And so I think that there's a lot of work in this space. And in the end, you can, of course, test. And there was Ziad Obermeyer came out with a playbook this summer. There's been a lot of other research that, or last summer, that has talked about how to do testing for software that does not work as well for one subpopulation as for another. But you can also have AI that's not biased per se, but it is unfair or inequitable. And that's often because of how you frame the problem or the actions taken based on the prediction. And an example of this is a no-show algorithm. So a no-show algorithm can predict who's going to show up and who's not going to show up. And you can have a fairly accurate algorithm, but the actions you take based on that prediction, which could be something like double booking the appointment or providing more supportive services to make sure those patients can come to the appointment, can really change whether you're making health outcomes more equitable or less equitable. And that's really that outcomes discussion that I saw in the chat box and has been the subject of previous discussions as well. But you can also say, okay, that's the action that's taken on the prediction. I can't necessarily control that quite so well. And this is a topic that came up in our December meeting. So you can also go back and frame the problem differently in the first place. So instead of predicting no-shows, I might want to predict what supports would be helpful in getting these patients to their appointments. And so instead of making an algorithm where you have to depend on the people taking actions that are equitable, you start by framing the problem in an equitable way. Next slide. So I want to run through some of these recommendations really quickly. I know we're short on time. When we talk about trustworthy products, we need to make sure that they're showing performance data on an independent test set and separate out performance among key subgroups to understand if they're biased. In real time, the software should be giving information around the certainty of the recommendations and when possible, show the key factors that cause the prediction or recommendation. Software products should be publicly disclosing at least summary information about the training data and the training process, including the patient population used in the training data. And the software also needs to clearly indicate the intended use, including the purpose, user, the significance of the decision, the level of autonomy given, and the patient population to all users. Data quality is really critical to trustworthy and equitable AI-enabled products. So manufacturers need to clearly define what data input requirements there are, including the structure and the definition of each data element. It's so easy to think about interoperability as really being a structure, but not necessarily the definition. And health systems really need to work to improve data quality and better understand, document, and mitigate bias within health data, and help the rest of the world understand where there are problems with health data. Health systems also need to be more open about their internal process challenges and informational needs, so manufacturers can develop products that solve real problems. And manufacturers and healthcare systems need to think of working together in a learning way to share information about performance after implementation and to share information around adverse and near miss events. So thank you again for inviting me. That's the end of my talk.
Christina, thank you so much. Amazing points that you've made in there. Really enjoyed your workshop that you guys hosted or your event that you hosted. And I know that many of the points you've raised, we're going to be continuing to talk on. I'm also really impressed by the chat. If any of the attendees aren't monitoring the chat, there's been a really interesting side thread going on. I want you to pay attention to the presentations, but also feel free to take advantage of the peer-to-peer interaction going on through the chat, asking some really interesting questions about who is responsible when AI goes wrong and things like that. Topics, no doubt, we'll get into throughout 2022. All right, so next, Cora Hahn will close us out in this section here. Thank you, Cora, very much, a former Fed who's now working with University of California Health as the Chief Health Data Officer. Cora, why don't you go ahead and take it away?
Great. Thanks, Stefan, and thanks, Catherine, and to the rest of the ONC team for having me here today. I'm going to spend just a couple of minutes talking about a recent set of recommendations that the University of California adopted to promote the responsible deployment of artificial intelligence across University of California operations, with a particular focus on healthcare. The recommendations come out of a system-wide interdisciplinary work group and a recognition that, as many folks here have already mentioned today, there are many benefits to the deployment of AI, including greater efficiency as well as better decision-making across certain functions. That said, absolutely, the use of AI raises equity, privacy, security, safety, and ethical concerns. And so there was a need to focus on developing a governance process that really prioritizes transparency and accountability in decisions about how and when the use of AI is deployed. The work was guided by an overarching set of UC responsible AI principles here on this slide, which are absolutely consistent with what many others have said here today. So first, appropriateness. The potential benefits and risks and the needs and priorities of those affected should be carefully evaluated to determine whether AI should be applied or whether in certain cases it should be prohibited. Transparency. Individuals should be informed when tools are being used, and to the extent possible, methods should be explainable to them, and individuals should be able to understand the outcomes as well as challenge them. Accuracy, reliability, and safety. Tools should be accurate and reliable for their intended use and verifiably safe and secure throughout their operational lifetime. Fairness and non-discrimination. This is a topic that many have covered today, but it is, of course, critical to have procedures in place that proactively identify and mitigate bias in AI tools. Privacy and security. AI tools should be designed in ways that maximize the privacy and security of persons. Human values. Tools should be developed and used in ways that support the ideals of human values, such as human agency and dignity, as well as respect for civil and human rights. Shared benefit and prosperity. Tools should be inclusive and bring equitable benefits, including social and economic benefits to all. And finally, accountability. The principle that the UC system should be held accountable for its development and use of AI systems in line with all of the other UC responsible AI principles. After examining use cases across 3 common areas, and those include business administration, clinical diagnosis and treatment, and quality population health improvement and chronic disease management, the group came up with a set of recommendations to operationalize these principles in the healthcare area. Next slide. Thank you. So first, a risk and impact assessment framework, and the development of framework that recognizes, as others have said here today, that the scale and scope of risks will vary and that greater accountability mechanisms need to be in place for those processes which raise higher risk. Second, documentation. And I want to spend 1 minute here talking about the importance of documentation for transparency, auditing, and oversight. That includes not only recording what AI technologies are being used, where, and for what purposes, but also information about the design of these systems. And I think this really builds upon work that Christina has discussed in her presentation. But of course, data that contains bias can produce bias. So it's critical to understand what training data is being used and why. And then to also note something that Devin and the FTC mentioned in her presentation, but it's critical to understand what is being used in the model as a proxy for what is trying to be assessed and to ensure that bias is not introduced in that manner. One of the ideas that came up in our system-wide group was the possibility of a model facts label for implemented models. Another recommendation is human review and monitoring. The need to develop and incorporate standardized, reproducible, and meaningful processes for human review at appropriate checkpoints. Fourth, encouraging representation, engagement, and feedback from the UC community, as well as from relevant external stakeholders. That needs to require work on promoting communication interfaces that help make AI systems actually understandable to diverse patient communities, as well as providing a mechanism to challenge any outcomes and address potential harms that might be caused. Providing training and educational programs. So this is often a basic thing, but is absolutely necessary to ensure that principles are actually translated across the board to actually implementation of these. Developing guidelines for the procurement process. This was a common theme across all of the domains, not just health, but definitely many tools are actually purchased and not just developed in-house, and may even be, in some cases, an ancillary part of a primary product that is being purchased. And for that reason, how to spot, how to identify, and how to mitigate risks are critical. And then finally, the final recommendation from the group was further research, including effective methods of monitoring AI to ensure accountability, and also ways of incorporating patient feedback into models that are developed. So the report is available online, and I will also, when the slides are put up, hopefully be able to provide a link to them as well as my contact information. But I'm very excited to continue the conversation because it sounds like there are many, many common themes that we are discussing today.
Cora, thank you so much, and really appreciate the work that you and the University of California Health are doing in this area to make sure you're deploying responsible health or AI and health IT. And like you said, sometimes it's part of the procurement process. Sometimes it's an ancillary piece of a procurement. There's something that the government's looking at as well, as how can we, put those best practices into that procurement process. Outstanding point. All right, so now we've got a slight modification. Luckily, we did have some padding between our break and the third part of the day, where we start to focus in a little bit more about the real world settings of deployment of these solutions. We're actually going to start back up at 2:35. So we are going to give everybody a few minutes of a break, and then we'll get started here shortly. So get up and grab a glass of water and take a bathroom break, whatever you might need to do. And then come back to your seats. Again, the good news is if you run a little long in your break, and when you come back and you miss anything, we are recording this. We'll be posting them along with all the slides, so you should be able to get caught up on anything you may have missed. We'll see you shortly at 2:35, and otherwise, we'll be on a break. Thank you. Okay, everyone, I show my clock is 2:35 p.m. Eastern, so we're going to go ahead and get started. Hopefully we've got our next tier of speakers lined up to present. In part 3, we're going to be focusing on evaluating data input needs and real world performance, kind of narrowing in on this focused topic. We've got an amazing lineup starting with representatives from the White House and from Congress, followed by FDA, HRSA, WellSheet, Mayo Clinic, Olive, Data Nutrition Project, Omega Concern, and Siemens Healthineers, who will co-present. So with that, I will quickly transition into our first presenter, Ms. Rashida Richardson from the White House Office of Science and Technology Policy. And she serves as a Senior Policy Advisor for Data and Democracy. Rashida?
Thank you for the introduction, and thank you to the ONC team for having us today at this showcase. There's a growing body of academic and governmental research that's increasingly demonstrating that while AI can be a powerful and useful tool in a variety of sectors and applications, it can also introduce risk, produce unintended outcomes, or worsen existing inequities within our society. These opportunities and problems are most pronounced, or particularly pronounced, when AI is used in healthcare. Our healthcare systems and practices are not perfect, so AI is often proposed as a way to increase efficiencies, mitigate implicit biases of clinicians or other healthcare providers, improve on human-based diagnostic and clinical practices, bridge societal gaps that impede health access, and aid breakthroughs on new and longstanding healthcare issues. Next slide. Yet, in order to advance such outcomes, AI used in healthcare, as well as consumer products related to health, must be designed with a nuanced understanding of our society and the healthcare sector. If these technologies are designed with a flawed understanding of the drivers of certain health problems or problems within our healthcare system, or without an understanding of challenges certain patient populations face, then they can be designed with bias flawed assumptions and lead to bias and flawed outcomes. If these technologies are designed without consideration of societal inequities and challenges such as the digital divide or barriers to transportation, then they can fall short in their intended goals or introduce new risk. If these technologies are designed without consultation or consideration of the end user or potentially affected patient population experiences, then it can result in counterproductive design choices that creates more friction or misgivings. We recently heard these concerns regarding AI model design from clinicians and researchers on a panel about AI in the healthcare system. This panel was part of a series of public events co-hosted by OSTP as part of our Bill of Rights for an Automated Society policy planning process. Next slide. This panel helped reveal that AI development involves lots of discretionary work. AI is often considered more objective because it relies on data. Its models are based on mathematical methods and reasoning, and it can operate at a volume and scale that surpasses human capacity. Yet most of these key steps of AI development involve several choices that may be considered highly technical, but are in fact policy decisions. And there are many reasons these highly technical choices are not seen as subjective and value-laden. For example, one panelist described his study of a healthcare prediction algorithm that is sold and used around the country to identify and triage care for patients with complex health needs. The study found that the algorithm exhibited significant racial biases, where healthier white patients were prioritized for extra care over sicker Black patients for all kinds of treatment. The researchers found that the software's bias stemmed from an unchecked assumption that were made during the algorithm design process. Since the software aimed to predict patients that were more likely to be sick and needed enhanced care, the developers had to choose what data could serve as a proxy for illness or worsening health conditions. And in this case, healthcare cost was used as a proxy. But since Black patients have unequal access to healthcare and the healthcare system tends to spend less money caring for Black patients compared to white patients, so when the algorithm was designed to predict healthcare costs, it undervalued groups that are locked out of healthcare or otherwise spend less money in the healthcare system. So biased outcomes produced by the software was the result of an underlying assumption in the design questions asked while the system was being developed. The developers could have considered other proxy variables, but the researchers of this study suggested that the healthcare cost was chosen for its convenience. In addition to convenience, some underlying assumptions in AI design go unchecked because they stem from long-standing medical practices or beliefs that are flawed, but not yet universally renounced. Another panelist demonstrated this problem by explaining that misguided use of race correction in diagnostic tools and practices. Race correction is where diagnostics are interpreted differently or adjusted based on the patient's race. Race correction came about because researchers would note racial disparities during clinical trials and decided to include race in the diagnostic equation rather than further investigating the outcomes. Researchers have also found that some of the original studies that led to race correction methods had no rationale for why race was included. With the emergence of AI, some of these diagnostic tools have been automated and continue to be used because they are considered to help provide personalized treatment. Yet our panelists emphasize that the continued use or automation of race correction in diagnostic tools is problematic, not only because race is not biologically or genetically robust category for treatment, but the reflexive focus on race distracts from other health determinants that may be more important to treatment and effective healthcare. With this example, one can argue that convenience is still a factor in AI design, but the reliance on and replication of longstanding practices in AI design resulted in the creation of technologies that not only reproduce harms of that problematic process, but can also serve to conceal it. The panel discussion clarified this related concern as well. Currently, researchers can return to their original studies of a diagnostic tool with race correction to identify assumptions or discretionary decisions in the design process. But if an AI system is not transparent or otherwise inscrutable, we may not be able to identify the source of error as a flawed assumption or discretionary decision. Overall, we learned that it's important for us to acknowledge and develop methods for identifying, documenting, and evaluating how human discretion and assumptions are introduced into the development of AI models. Understanding this role of human discretion and assumption is not only important for identifying it as a source of error, flaws, and bias, but it's also important for developing appropriate policy mechanisms and industry best practices to ensure AI is developed to produce equitable outcomes and improve healthcare. Before I close, I want to note that there's an opportunity for this community to directly act on the observations and recommendations of my presentation. OSTP recently launched an RFI on our Community Connected Health Initiative, which is focused on how innovation in science and how innovation in science and technology can lower barriers for Americans to access quality healthcare and lead to healthier lives by meeting people where they are in their communities. We are interested in hearing from all stakeholders about successful models for strengthening community health systems through AI-based technologies, barriers to uptake, how user experience is measured, need for tools and training, ideas for potential government action, and more. So please submit your ideas and comments by February 28th. Thank you.
Thank you so much, Rashida. And again, thank you for highlighting the RFI you just put out. I hope people check that out and respond to it on community health and technology, as well as thank you for highlighting the amazing panel that you hosted a few months ago. And I may be biased because it was Mickey Tripathi, our very own national coordinator, who was selected to moderate that panel. So thank you very much again. And I will now transition over to, as a nice segue, because many of the same topics on race data are going to be further explained with our next presenter, Ms. Rachel Dolan, professional staff with the Committee on Ways and Means and the majority staff. So Rachel, why don't you take it away?
Great, thanks so much. Good afternoon. I hope everyone's still awake out there. Glad we got a little bit of a break, even if it was cut short. Wanted to start by saying thank you to ONC for the invitation to speak here today about some of the work that we've been doing on health and economic equity at the Ways and Means Committee. As was said, my name is Rachel Dolan. I'm professional staff with the Ways and Means Committee working for the majority. I lead work related to Medicare fee-for-service and health equity, which I'm going to talk about today. But before I start, I just need to give this brief caveat that everything I say today is a reflection of my opinions and my opinions alone, not a reflection of the chairman of the Ways and Means Committee or the committee writ large. So now that that's done, let's dig into it. Next slide, please. So briefly, let's start with a little context on the work the Ways and Means Committee has done, led by Chairman Richard E. Neal over the last few years related to addressing health and economic equity. So before the pandemic really raised public awareness about the health and economic inequities that have been really so structurally ingrained into our country for centuries, the committee began examining these phenomena. So in July 2019, Chairman Neal, along with Ranking Member Brady, put together a bipartisan rural and underserved communities health task force to really dig into the factors leading to disproportionately worse outcomes in certain areas of the country, particularly, as the name implies, rural and underserved communities. So this work led to a report that we put out in July of 2020 called Left Out: Barriers to Health Equity for Rural and Underserved Communities. Along with that, we've also held a number of other hearings related to issues that look at the intersection of equity, our history, and health and economic factors. To name a few, we've looked at the public health effects of gun violence, the maternal mortality and morbidity crisis, aging and caregiving, the ways the tax code subsidizes hate, issues related to climate change, and also, importantly, the disproportionate impact that COVID-19 has had on communities of color. And so based on these exploration in early 2021, we released a report and associated policy pillars document where Democrats on the committee really laid out a pathway to reform related to health and economic the health and economic systems to address these inequities. I mean, I think the important thing to point out here, as we've been saying, is we're not going to solve 400 years of history and 400 years of problems in a single year. But as the chairman has said over and over, we need to start somewhere. And so as a product of that, we also put together the Racial Equity Initiative on the committee, led by co-chairs Terry Sewell, Stephen Horsford, and Jimmy Gomez. And you can see all of this equity work at the link on the slide. And I think my coworker's putting it in the chat as well. So please take a look at that. So next slide, please. So as part of this health equity work, we started also exploring technology, which is the subject of this conversation today, particularly related to clinical decision support tools and also telehealth, everyone's favorite topic these days, and looking at the ways it has the potential to both improve health outcomes on the one hand, but in some cases, the potential to exacerbate existing disparities if we're not careful. So in October 2021, we released the report listed here, which I'll talk about for the next couple minutes. It's called Fact versus Fiction: Clinical Decision Support Tools and the Misuse of Race. Next slide, please. So the purpose of this report was to look at clinical decision support tools, also called CDSTs, but also examine their potential for racial bias and ultimately harm. I'm sure the audience here has a good sense of the utility of these tools, so I'm not going to dwell on that. But the report specifically focused on clinical algorithms, sort of a subset of CDSTs that aggregate research, large amounts of data, other statistical models to guide clinical assessment, risk prediction, and decision-making. Essentially, these are just more sophisticated CDSTs. So our work was prompted by a June 2020 New England Journal of Medicine article that showed a link between many of these tools and also racial bias and worse outcomes for patients. Chairman Neal was very interested in this, and so we sent out a series of letters to professional medical societies, as well as a broader request for information to assess the landscape and really see what was going on. The purpose was, multifold, but really to focus on assessing stakeholder and community awareness of the potential for bias and these potential issues expressed in the New England Journal of Medicine study, what organizations were doing or considering doing with respect to change, and assessing the role of other healthcare actors in addressing this potential for bias, racial bias specifically. Next slide, please. So briefly, we spent quite a bit of time looking at the information sent back to us and analyzing it, and essentially, the response to the chairman's letters and the broader RFI reflected sort of the tacit acknowledgement of the unacceptable nature of these findings, that certain CDSTs produce avoidable differences in outcomes for patients of colors. Notably, 1/3 of organizations and professional society respondents said they are not planning on reevaluating the use of race and ethnicity in clinical algorithms, even after a number of studies over the last couple years, dovetailing from the New England Journal article, have pointed out biases and the potential for worse outcomes among communities of color. A number of respondents pointed elsewhere to request help in addressing these issues. Some noted the absence of essentially a central hub of accountability as a barrier to addressing these complex issues. Some suggested influential stakeholders like the Centers for Medicare and Medicaid Services, potentially ONC, other government actors should get involved in convening relevant stakeholder groups to discuss standards, guidance, other best practices related to CDSTs in this challenge with the underlying race and ethnicity data. And some suggested really responsibility lies upstream at the development of these tools, and also in the medical education of clinicians. I think the good news is ultimately most respondents noted that addressing health inequities will require acknowledging these structural inequities present in the clinical science and in clinical science and medicine from years and years and years of biased work. And then many still expressed a general willingness to be accountable for their impact on persistently disparate health outcomes. Just as far as takeaways briefly, I think the report helped us acknowledge that we cannot take for granted that, the technological tools we have in place that are available to, in theory, improve outcomes uniformly affect everyone the same. Importantly, underlying data systems are subject to human and structural biases, whether or not we realize they're there, and we need to treat them that way, or else we'll have the potential to exacerbate rather than mitigate health disparities as we look to a future of healthcare delivery that very clearly increasingly will be incorporating technology. So thank you. Appreciate your time, and good luck to the next speaker.
Thank you, Rachel, so much. It is really a fantastic report for those who haven't seen it yet. I highly encourage you to look up that report. The links are in here, and I think, as she mentioned, they were dropped into the chat. Very easy to read. Does a great job of giving some historical context to CDSTs and how bias may have been introduced, dating all the way back to the beginning of the development. So highly encourage people to check that report out. Coming up next, we have Sean Forrest, the other half of the tag team from FDA's Center for Digital Health Excellence. And so, Sean, why don't you go ahead and take it away?
Great. So my name's Sean Forrest. I'm a digital health specialist in the Digital Health Center of Excellence at the FDA. So I'd like to talk to you a little bit about good machine learning practices and real world performance for AI and ML enabled medical devices. Next slide. So as my colleague Aubrey Schick discussed earlier, we've been collaboratively exploring the best approaches to regulating AI/ML enabled devices for several years. And in April of 2019, it published a discussion paper that proposed a total product lifecycle, or TPLC, approach to regulating AI/ML enabled devices. This includes components such as a culture of quality, pre-market assurances, and a pre-specified change control process and real-world performance monitoring. Next slide. After publishing the discussion paper, we received quite a bit of feedback from various stakeholders, and I won't go through all these, but if you go to the next slide, this slide shows several of the milestones that resulted in publishing an AI/ML device software action plan. And those key actions are shown at the bottom of the slide. And I'm just going to highlight a couple of them that seem most related to this session. Next slide. So we heard feedback from our discussion paper primarily in these categories. And as a result, we identified associated actions. You can go to the next slide. So I've highlighted the actions associated with good machine learning practices and advancing real-world performance pilots to cover here. I'll note that Aubrey also described action 3 in the last section. Next slide. So focusing on the second action related to good machine learning practices, or GMLP, these are accepted practices of algorithm design, development, training, and testing to help ensure quality machine learning algorithms. And these are practices drawn from quality systems, software reliability, machine learning, and data analysis disciplines. And I highlight the culture of quality in the AML workflow because they're practices that pertain to organizational excellence, but these practices apply to all aspects of this workflow. Next slide. Some resources for identifying GMLP are standards development organizations and committees and relevant collaborative communities. We're also working with an AI medical devices working group within IMDRF, which is the International Medical Device Regulators Forum. Next slide. I also want to point out that we just published 10 guiding principles associated with GMLP last fall. And on the next slide, these principles are intended to lay the foundation for developing good machine learning practice that addresses the unique nature of these products. They'll also help cultivate future growth in this field. They identify areas where the IMDRF, international standards organizations, and other collaborative bodies could work to advance GMLP. And areas of collaboration could include research, creating educational tools and resources, international harmonization, and consensus standards, which may help inform regulatory policies and regulatory guidelines. Next slide, please. The final aspect of the action plan is about using a total product lifecycle approach to AI/ML software that's supported by real-world performance monitoring. Gathering this information during the actual use allows manufacturers to better understand how the software is being used and identify opportunities for improvements, as well as proactively respond to any safety or usability concerns that are identified. Next slide. Our action plan described that we'll support piloting of real-world performance monitoring with stakeholders on a voluntary basis. We coordinate this work along with other ongoing FDA programs that are already focused on use of real-world data. And through this process, develop a framework for seamlessly gathering, validating, and evaluating real-world performance metrics. And we'll be continuing to engage stakeholders on this topic. Next slide. And if you have any questions about these topics or others part of our action plans, you're welcome to reach out to our digital health mailbox or me directly with this contact information.
Sean, thank you so much. We greatly appreciate taking the time to present on this today. And I'd like to also acknowledge the international collaboration there as well that you had on one of your earlier slides. It was, it's been critical having FDA as part of the Global Digital Health Partnership on the AI machine learning work stream that they've had underneath that as well. So thank you so much for that. And now we will transition to a group part presentation where we've got a couple of representatives from HRSA, an HHS agency doing amazing work in this area, especially as it relates to community health, and who will tee us up and set up the next group of the additional speaker that we have from Alliance Chicago, who will present on some of the grant funded work that they've collaborated with together. So with that, I will turn it over now to Janelle Parham and Candace Webb from HRSA.
Thank you very much. Greetings to everyone. My name is Lieutenant Commander Janelle Parham, and I am the Health IT Health Center Control Network Team Lead in the Strategic Partnerships Division of the Office of Quality Improvement in the Bureau of Primary Health Care at HRSA, the Health Resources and Services Administration. I'm joined today by one of my colleagues, Candace Webb, and we are delighted to be a part of today's showcase. The Bureau of Primary Health Care oversees the Health Center program, a national network of nearly 1,400 funded health centers and lookalikes that have provided affordable, accessible, quality, and value-based primary health care to more than 27 million people nationwide. These health centers serve 1 in 11 people at the more than 13,500 service delivery sites in every U.S. state, U.S. territory, and the District of Columbia. And they lead the nation in driving quality improvement and reducing healthcare costs for America's taxpayers. Health Center Program awardees are supported by HRSA-funded technical assistance partners, which include the Health Center Control Networks, also known as HCCNs, National Training and Technical Assistance Partners, and primary care associations. The HCCNs are uniquely positioned to provide specialized training and technical assistance to their participating groups of health centers by making health information technology easier for patients and providers to use, increasing the security of patient information, using health information technology to reduce costs and improve care coordination, and using data to improve patient care. Now I'm going to turn it over to Candace Webb to discuss Alliance Chicago and their AI projects that brought us to the showcase today.
Thank you, Janelle, and thank you to Stefan and our federal partners at ONC for this invitation to the showcase to showcase some of the trustworthy AI work of one of our HRSA-supported Health Center Control Network partners, Alliance Chicago. Alliance Chicago is a leading health organization whose mission is to improve personal, community, and public health through innovative collaboration, health information technology, and health research and education. HRSA's Bureau of Primary Health Care supports digital health innovations in the Federal Health Center program through our funding opportunities to strategic partners like Alliance Chicago, including the responsible and ethical use of AI tools to meet the diverse and ever-evolving healthcare needs of vulnerable populations and to promote equitable outcomes for underserved communities. I'm pleased to now turn it over to our partner, Dr. Neeta Mohanty, the Chief Research Officer and Director of Evidence-Based Practice at Alliance Chicago.
Well, thank you so much, everyone. And thanks to our partners at HRSA for the kind introduction and to the ONC for hosting this wonderful program today. My name is Nivedita Mohanty, and in addition to being the Chief Research Officer at Alliance Chicago, I'm also a practicing physician. And I'm really delighted to share some of the projects that my close colleague, Andrew Hamilton, and I have worked on with our teams and our dear partners in the public health and academic space to bring these projects together and present them to you today. Next slide, please. And the next slide. So the first project I'll talk about is a diabetes risk prediction project and really using artificial intelligence in our approach. I want to start off by sharing some of the background for this project. We had actually embarked upon a research project with our colleagues at Northwestern. And in the course of that study, we learned that very many of our patients were actually being missed through the USPTF clinical guidelines for diabetes screening and prevention. And we saw this as a really wonderful opportunity to embark on a new analysis and opportunity to leverage AI with our partners from the Data Science for Social Good program and the University of Chicago. So one thing I might draw your attention to is the graph that's on the left-hand side, and you'll see some red crosshairs there. In that middle quadrant are the number of patients that were actually eligible for diabetes screening using some of the standard guideline-based screening. And recognizing that many of the underlying studies that build a body of evidence often exclude patients or didn't include patients that are part of community health centers catchment area, we thought that this was a really exciting opportunity to leverage our data infrastructure and our partnerships, as well as using some public data sets to take a more personalized approach to identifying patients who are at risk for diabetes. So with the graphic on the right, you can see that while, of course, age and body mass index are very important indicators for predicting diabetes, there are also very many other variables that could really be essential in developing predictive algorithms for identification of diabetes risk. So the opportunity here was really a personalized tool for clinicians to identify patients at risk and intervene early. Next slide, please. For this project, we leveraged a lot of clinical data that was in our data infrastructure, and that included electronic health record data on over 1 million patients. It included 24 health center organizations across the country and over 8 million clinical visits. One thing that was so important to us was, in addition to some of the clinical observations and inputs that you can see on the bottom that you would get from a traditional electronic health record system or registration or administrative fields, we also felt it was so important for us to be able to relate this to the social context of our patients. So with the work that we did with our wonderful data science partners, we were able to use external data sources like that of the American Community Survey alongside clinical data that we were able to provide from the health centers that we serve. In the end, when we looked at the analysis and the end products of this project, we were able to develop a risk algorithm that would predict risk anywhere from a 6-month to 3-year trajectory for a patient. And when we did some of our preliminary analysis, we found that it was more effective and accurate in terms of identifying true cases of patients with hyperglycemia than some of our current screening conventions. And so the plan is to really take this to the next level and put it in the form of clinical decision support tools and further train the model. Next slide, please. So this project is focused on early lead remediation and prevention of lead poisoning in children. And as many of you may know, lead is still a problem in some cities in the United States, even though there have been major strides to eliminate lead risk. Our convention, however, for identifying lead is still pretty reactive. Kids are poisoned, they're screened for lead, we find lead in their blood, and only then do we trigger activities for remediation or abatement. With this project and generous support from the Robert Wood Johnson Foundation, we collaborated with the Chicago Department of Public Health, the University of Chicago, and the City of Chicago to develop a lead risk algorithm. And on the right side, you can see exactly what the clinical decision support tool looks like in the electronic health record, where at the point of care, a provider could be surfaced this lead risk predictor and an analysis can be made, and a recommendation to actually refer a child for their home to be inspected for lead. And the idea of this was to make this available for pregnant women and for infants, such that lead risk could be surfaced even before a child was ever poisoned. Next slide, please. The title of our talk was multi-sector collaborations, and doing so to use predictive analytics in community health. And I think this project, just like the last one, shows the power of combining different data sets to arrive at a more robust predictive tool. As you can see here, the risk algorithm wasn't just based on home address or just based on past clinical data like lead values, but actually included several other public health and city data sources, including home inspections and building permits to develop the prototype model. And in the box that you see at the bottom is exactly how the API worked. So the way that clinicians were able to use this at the point of care is that they were able to trigger an API data exchange between Alliance Chicago's hosted electronic health record and the City of Chicago, where the predictive model is housed. there are specific discrete data elements that were shared, and then a risk score was returned back to the EHR to surface the risk at Alliance Chicago sites. And in our work with data validation, we found this to be a very accurate in terms of predicting high-risk neighborhoods where kids are living, and is a really wonderful opportunity to really leverage a proactive approach to identifying lead at a location or a building rather than detecting it in the blood of children. Next slide, please. So with that, I thank you so much for the opportunity to be with you today. And if there are any questions, we're always happy for you to reach out. Thank you so much.
Thank you so much, Nivedita, for that amazing presentation. And it's exciting to see work from years ago that I was involved with or aware of on the lead side, where it was based on the City Department of Public Health just doing the inspections more accurately and getting to houses with the limited inspection team that they had. Seeing that now boil all the way into putting some of that information, actionable information, into the hands of the patients themselves. So outstanding work by the city, by Alliance, by HRSA, and helping fund this work, and all those others who are involved. Thank you very much. All right, next, we're going to transition somewhat related. There's a little bit of overlap because we've got Alliance Chicago also participating as a backup support to this this next presentation. We've got Craig Lamoli, the CEO of WellSheet, who's going to talk a little bit more about AI-supported clinical workflows to make EHRs more actionable and intuitive. Craig?
Hi, everyone. My name is Craig Lamoli. I am the founder and CEO of WellSheet. I do want to note that I'm also joined by Dr. Fred Rockman, of the CEO and Chief Medical Officer of Alliance Chicago. So we're excited to talk to you about our partnership together to really use AI to transform the EHR experience with better decision support tools. And I'll hand it off to Fred to start with that vision.
Fred, you might have to unmute yourself and turn on your camera. Let's see, might be having technical difficulties.
If Fred is unable to join, that's no problem. We can go ahead and dig in here.
Here we go.
There we go. Sorry about that, Fred.
Not granted permission to unmute there for a bit. Thanks for unblocking me. So thank you.
No worries.
Yeah, thank you. It really is both a privilege and honor to be able to preface Craig's remarks today, both because I am so excited to support ONC's leadership today in advancing the thoughtful application of AI, and because I so admire the vision and work it took for Craig and his team to make WellSheet available. Any of you that had the opportunity to hear my colleague Nita Mohanty speak a few minutes ago might have a glimpse of the role that we feel AI and advanced application of HIT holds for Alliance Chicago and our stakeholders. As early champions and adopters of HIT and the safety net, we've labored at the ground level. It's been hard work to implement EMR with an eye to the power, eventually, of connecting the collection of data in the process of delivering care with the ability to contribute to, not only leverage, but contribute to the evidence-based data and complete patient-level information in order to make the best possible care decisions. Advancing health information technology and advancing analytic tools have only really made that vision more exciting and attainable. So we are working with more than 60 health centers across 19 states and have built a database that encompasses longitudinal healthcare data from more than 3 million patients, representing the full spectrum of health disparities. It's an incredible sandbox, and it's a deep responsibility. And from our basis in the safety net and community health centers, we of course place special emphasis on health equity and on the incorporation of a broader concept of health and healthcare than just medical care as part of the data that informs AI. and the importance of prioritizing the interest of consumers. We were drawn to Wellsheet for what we see as its powerful potential to enable us with some of the key challenges that we see ahead. First of all, improving how information is accessed in the EMR to more efficiently and responsively support care delivery, specifically to both improve how insights are translated into care, as well as to help with better capture of information in a meaningful way. Second, to have the ability to broaden the range of information included beyond EMR data, to recognize the richer set of information, including that relevant to social determinants of health. Third, to be able to seamlessly leverage developing interoperable national level clinical decision support and evidence-based recommendations into real time into our tools. And finally, a way to make the insights and tools available across key EMR platforms, liberated from an individual healthcare platform, in use across our collaboration. So with that introduction, let me turn things over to Craig to introduce you to Wellsheet in a more detailed way.
Thank you so much, Dr. Ruckman. We're really excited about our partnership with Alliance Chicago for the reasons that Dr. Ruckman mentioned, and we really share a mission to empower clinicians to better care for the underserved populations that the FQHCs that Alliance Chicago serves are really focused on supporting. And we're thrilled to incorporate the powerful set of decision support resources that Alliance Chicago takes a lead on developing effectively into the clinical workflow. And next slide. Wellsheet is really designed to anticipate what clinicians need to know about a particular patient from the EHR and other sources. Wellsheet's embedded into the EHR workflow through seamless API-based integration and pulls in data from the EHR, like Epic, Cerner, or athenahealth, and prioritizes that content based on the clinical context to really show clinicians the content in the way they want to see it. Wellsheet also integrates data from sources outside of the EHR, including the decision support resources that Alliance Chicago develops, as well as clinical data from HIEs and payers to provide a more longitudinal view of the patient's medical history to the end user, all seamlessly incorporated into their EHR workflow. Next slide. So Wellsheet's embedded within the EHR through FHIR API standards, allowing clinicians to access Wellsheet with a single click from the patient chart in the EHR. The full Wellsheet functionality is also available on the go through our mobile applications, accessible with single sign-on through FHIR protocols, and supports use cases around chart review, care team collaboration, and decision support, as we've mentioned, across all of these mediums. Next slide. So Wellsheet doesn't generate its own clinical decision support content, but rather supports the delivery of the best content into the clinical workflow in an intuitive and user-friendly way. So we surface the most relevant decision support resources alongside the most relevant patient information to really enable physicians to make guideline-based decisions for their patients in a much easier way, all in a unified user experience. Wellsheet predicts what clinical views are most relevant for the clinician to see, and then continuously optimizes the presentation of that information based on usage. As all of our physicians, clinicians across the country interact with the system, we're constantly monitoring to get better and better at predicting what to show to clinicians by default. And this is really through our patented machine learning models to be able to constantly learn from that clinician interaction with our system. Our usage of AI is entirely designed to empower clinicians to make treatment decisions rather than to tell the clinician what to do, which we feel is the most transparent and responsible way to utilize AI and machine learning in patient care. Next slide. So by predicting what content clinicians need to know about patients, Wellsheet is able to reduce the burden on clinicians through more efficient interaction with the EHR. We've seen really substantial reductions in the amount of time that physicians have to spend in the EHR, up to 40% at clients that we've deployed this to. It's really resulted in outstanding levels of satisfaction and adoption across the health systems we've deployed to, and we're really excited to be working with Alliance Chicago to bring this to the underserved communities that they serve through FQHCs across the country. So we are really looking forward to this I think, incredible match of core competencies between our organizations with Alliance Chicago, generating really exciting advancements in clinical decision support, and Wellsheet being able to really get that decision support effectively into the clinical workflow at the point of care. We look forward to speaking with anyone who's interested in learning more as well. Thank you.
Thank you, Craig and Fred, so much for your comments there. It's I think a good example of how it's a partnership when it comes to deploying AI, between EHR vendors, between organizations and healthcare providers like Alliance and FQHCs and those in community providing services, and third-party vendors like Wellsheet, who need to help kind of all monitor the implementation of that solution. Okay, next coming up, we have Emily Wampfler with the Mayo Clinic, who's the Senior Director of Product Management of the Mayo Clinic platform. Emily?
Thanks, Stefan. Hello, everyone, and thank you so much for the opportunity to present today. It is just really refreshing to hear this conversation and see so many folks in this community that are all really passionate about seeing AI developed ethically and implemented within healthcare. Many of you are likely familiar with Mayo Clinic. Mayo is an academic medical center with 3 destination locations in Minnesota, Florida, and Arizona, and also has a health system in the Midwest region surrounding Rochester, Minnesota. Mayo is working on similar AI playbook concepts that I have heard from some of the other academic medical centers to enable ethical development and implementation of AI internally. Mayo Clinic platform is a little different, and you may not have heard of it yet. It is a business unit that was formed within Mayo a couple of years ago, founded on Mayo Clinic values, as well as the commitment to complex clinical care, medical research, education, and data science, but focused on servicing the external market. Dr. John Halamka, who you'll be hearing from at the end of today's sessions, serves as the president of Mayo Clinic platform. I thought it would be helpful to explain why Mayo Clinic platform was created and an overview of what we aim to do. Next slide, please. The vision of Mayo Clinic platform is to create a healthier world where personalized, predictive, and innovative care is accessible to all. We know that Mayo Clinic has a position of #1 in the world in terms of care, but that care is not accessible to everyone. So we want to go from the millions of patients that have benefited from the receipt of Mayo's clinical expertise and take that number to billions. This is an audacious goal, but that's where we're aiming, and I will humbly explain how we believe we can achieve that vision. So you'll see on this slide that Mayo Clinic platform really wants to sit in the middle and be an enabler of new knowledge, new solutions, and new technologies for the ecosystem on the left. The ecosystem on the left are those companies that are creating technologies or services for clinical decision support, medical devices, virtual care delivery, and more to change how healthcare is delivered for the patient-surrounded ecosystem of care on the right that will ultimately lead to that healthier world. In other words, we want to be seen as a supercharger of the organizations on the left-hand side so they can become better at delivering services for the right-hand side. And we want to do that with our products, which are meant to be purchased by the ecosystem on the left, and empower those companies to develop AI that enhances their products and services. Next slide, please. We have a portfolio of 4 products, and as I walk through them, you'll hear how fundamental data is to each of the products, and therefore the importance of its quality and management. Let's start with the Gather product. This product will ingest data coming in from a whole host of endpoints. Those endpoints could be ECG devices, continuous glucose monitors, devices capturing radiological images or health record data, really any data that sits at the edge that is patient-centric. Gather creates the integration into those endpoints so the data can be ingested, normalized, curated, stored, and then de-identified. The second product is the Discover product. Discover is the product connected to the de-identified data, some of which that was collected by Gather. This data, along with tools that sit on top of the data, allow for true data science work that leads to the development of new AI. These new insights may arise through using the data as real-world evidence to support the development or lifecycle management of drugs or devices. Or it could be from the development of new algorithms for clinical decision support. A fundamental principle of this product is that the data itself is never exported from a secure data science environment. This allows us to maintain quality of the data. Rather, tools are brought to the data and only the AI models or results from analysis can be exported. The Validate product serves as a testing laboratory to evaluate AI models for reasonableness and usefulness of the result. Validate is enabled by a cryptographic technology that protects the privacy of the data from the data provider and the intellectual property of the algorithm from the algorithm provider. We believe that that if any healthcare stakeholder can test any algorithm against any data set and evaluate the usefulness of that result, this will lead to adoption of AI by credibility that's built from the bottom up. So if you look at what we have that's comprised of gathering data, discovery of algorithms, and validation of those algorithms, what is left is to deliver that wisdom into workflow. And that is the goal of Deliver, to integrate algorithms and insights into clinical workflow to optimize the experience of providers and care for patients. Next slide, please. So again, Mayo Clinic platform and our portfolio of products is looking to power the ecosystem of producers of healthcare solutions on the left for the benefit of the patient-centered care ecosystem on the right. We sit in the middle and aim to enable AI developers to ultimately benefit patients with faster, better, and more scalable care. We believe that ensuring that the data we make accessible to those developers is high quality, standardized, and secured will help lead to AI that performs as intended in the real world. Thanks again for the time today.
Emily, so apologies, I didn't go through the transition quite as quickly as I should have probably for you, but I think folks are getting to see the complete picture on that last slide.
Okay.
So thank you so much for breaking down the platform. I find it really interesting that Mayo Clinic made the decision to not only provide these services and develop these offerings as something for internal purposes as the right thing to do, but also as a business unit, right? To make it a self-sustaining business unit, I think was a really great idea. So thank you again. And we look forward to John's comments on the closing panel. All right, so next we have with us Rohan D'Souza, with the Chief Product Officer with Olive. Rohan? You may be muted still. There we go. Perhaps a double mute if you're on the phone as well. We're having some technical difficulties with your audio. It's still not coming through. I could see your mouth moving and I could see it is unmuted through the platform, but that's what I was wondering, if you're on your phone, it might be muted there as well.
How about now?
Yes, perfect. Great.
Awesome.
Take it away.
Thank you. Thanks. I've got like 3 mics here. Needed to pick the right one. Well, first of all, thank you so much for having me. I'm going to take us on a little bit of a different spin with AI today and talk specifically about automation and how we're building using AI embedded in relieving a lot of the pressures and the burnout that we're having today with various different systems that are required to run and sort of serve as the beating heart for healthcare operations across at least the United States. So next slide, please. So just some rooting in who we are. I'm representing obviously the private sector today. At Olive, we are deeply rooted in this concept of the next wave of intelligent automation. Specifically, the intelligence piece is why I have the pleasure of speaking to you today about how we are embedding artificial intelligence into the core concepts of assisting humans in day-to-day rote mundane tasks, but being very empathetic in our approach. Just a quick slide on what McKinsey believes is the market potential for AI. We've talked a lot about this today, and what's gotten a lot of interest on the private sector. If we go to the next slide, I just want to give you some context as what this means from a healthcare perspective, right? So if we look at the current state today, things are not looking good. Simply put, we're in a little bit of a crisis. There are three main areas that desperately need focus, and everyone's willing to provide a lending hand. First, I represent today primarily the cost pressures that exist and the administrative burnout that we think AI could provide a significant amount of lift and a relief valve on the system. Over $1 trillion is spent today on administrative overhead. Yeah, that's 1 trillion with a T, most of which is coming on the large provider and payer side of the house. Cost is obviously degrading human-centered connection. We are working today primarily in systems that humans are working for rather than the systems working for humans. And we believe that AI can provide that massive amount of liberation to humans. And then last but not least, this is degrading the ultimate human healthcare worker. People have dedicated their lives to help others and are being asked to do way more administrative tasks, really taking away that human connection from the patient. So at Olive, what we're doing on the private sector, if we go to the next slide, is we stole a little framework and guide from one of world-renowned AI researchers turned author. For some of you who follow Kai-Fu Lee's work, this will probably look familiar to you. And so we sort of have this 2x2 matrix where we're strong believers that AI isn't the solve for every single problem. But as we approach the application of AI in the specific workflows and in the bolus of running health systems today, either on the provider side or on the payer side, and soon to be with the patient side, we apply this framework to say, do we need to envelop AI with a human aspect where you require a lot of compassion, where in some cases you can provide a task to be fully run by an assisted intelligence bot or an intelligence bot to perform a rote mundane task that now liberates a human to perform a much more empathetic, or as Kai-Fu Lee would say, the love angle that's required for humans to interact with humans. And so if we go to the next slide, I just wanted to give you some real world examples of what we do as a company and where we're infusing AI into our workflows. One of the areas that is providing a crushing pressure across the four angles of the quadruple aim is the process of a prior authorization. And so we're leveraging components of automation, artificial intelligence, clinical NLP, and systems architecture to deeply understand whether an authorization is required. We then handle all of the medical necessity guidelines and do some pretty robust deep neural net work where we do clinical embedding and clinical documentation package assembly. So now humans don't have to worry about what documents do I need to gather in order to send to my health plan. We have the AI system fully handle that, but very much with a human-esque training and annotation process, which then performs a submission and the statusing to relieve a lot of the pressure on tasks, which are some stats that we have down here at the bottom around productivity increase, the reduction in write-offs, bad debt, and ultimate revenue implications to the system that's moving in this direction from fee-for-service into towards value-based care. I believe I have one more slide and then can turn it off to the next presenter. The other thing that we're deeply rooted by on the private sector is we often hear this comment that healthcare is really not the place where innovation happens on the technology side. And we think that that is no longer going to be the case. In fact, the movement is already happening for really, really robust, empathetic led innovation happening in the trenches of healthcare that soon other industries will start to pick up from. Today, we take a lot of feedback from what's happening on the outside and bring to healthcare, but I think we're soon going to become this beacon of innovation that other industries are going to pick up from, especially around handling concepts of ethics and removing inherent bias across the other industries. So that's all I wanted to say. Thank you for having us, and I'm excited to hear the rest of the talks. It's been a fantastic event and look forward to the panel.
Great, thank you, Rohan. And we look forward to having your thoughts on that final closing panel as well. And I love the optimism. I love the optimism about us becoming the industry that becomes the leader and others look to for examples, especially when it comes to ethical and responsible use of AI. All right, so now we will go ahead without further ado, transition to a really fascinating project that I learned about through the Duke Margolis event that was referenced earlier today. We have with us Kasia Shemilinski, who's one of the leads for the Data Nutrition Project. And Kasia, please take it away.
Fantastic. I hope you can hear me okay. My name is Kasia Shemilinski. Thanks again for inviting me. I'm going to talk a little bit about the importance of healthy data, right? So high quality data when it comes to AI and the types of things that we're thinking about to help to mitigate some of the harms that we see by looking first and foremost at the data. So you can go to the next slide, please. Just a little bit about me and what I do. I'm a researcher at the Partnership on AI and also at Harvard, and the co-founder of a group called the Data Nutrition Project, which aims to build tools, policies, have conversations around data set quality, in particular to mitigate bias in AI. Next, please. So the problem, and I think that many people have talked about this in different ways over the course of today's event, is that you are what you eat, right? So we're really gonna drive home the nutrition and the food analogies today. So I hope that you can bear with me on that ride. But really, if you feed an AI system data that is incomplete or biased, the AI system is going to exhibit problematic outcomes that are very similar to those that were in the data. And these are just some recent examples that made the news. Next slide, please. So there's another, all right, if we're going to dive into an example, which I'm excited to do here, what happens if you don't eat well, right? So we all know as human beings what this means. What does this look like when it comes to data and AI? Next slide, please. This is work I like to showcase as a partner of ours, Dr. Rodenberg, who's a dermatologist at Memorial Sloan Kettering. This is some ongoing work that she's been doing, and we've been working with her on this data set here about images of melanoma. So what I think that sometimes pictures are just worth a lot more than me talking a bunch. In the middle here, you can see there's a picture of a skin lesion that is cancerous and then one that is benign. And you can see that if you look at the top AI algorithms, I think this is as of 2019, the sensitivity of the algorithms is actually better than the dermatologists in some of the case. So there's a huge opportunity here for AI helping to identify melanomas or at least high risk situations so that people know that they should go get care, so that they can adequately get the kind of attention that they might need at that moment, so they can catch the melanoma before it spreads, right, before it continues. But on the right-hand side, you can see what might happen in the case that an image training data didn't make it into that data set, right? So on the right-hand side, this is from a different clinic. So clinic A, obviously those images are following a certain standard that maps to the way that the algorithm was trained initially. From clinic B though, you have a picture of a melanoma here that maybe has a different, light situation. Maybe the zoom is off, and all of a sudden the top AI algorithms that could have a 90% sensitivity for the left-hand side are dropping to just over 1%, right? Which is kind of horrifying. So this again is you are what you eat, right? So the kinds of data gaps that you have in your training data sets are really going to affect your AI outcomes. Next slide, please. So the problem that we were just looking at is you are what you eat, right? But what if you don't even know what you're eating? I think this is the next level of issues that we might see here. If you go to the next slide, please. So this is a bunch of words here, but essentially, if you don't have transparency into the data itself, you might never even know that there is bias. This was a study that was done here that it was a study of studies, right? A review of studies around melanoma and AI. And there were only 20% of studies that included description of patient ethnicity or race, which matters with regards to skin type, as well as only 10% had any information about skin tone at all, right? Forget race and ethnicity, just skin tone. So in a lot of cases, we're looking at buying, creating, using AI without even knowing if there might be a bias because that information isn't collected about the data, about the training data. And on the right-hand side, there's just some images here. If you don't even collect this kind of information, you can't even test your algorithms to see whether darker skin tones or different anatomical areas would even do well because you don't have that data and you don't know how those AI were trained. Next, please. So the work that we're doing, we call this dataset nutrition labels, really just to push that nutrition analogy all the way. And what we're trying to build, next slide, please. Oh, I think the next slide is actually my team. I just want to say it's not just me. I have an amazing team of people. We're all working on this together. Next slide, please. So what we're working on here is this opportunity that we see to interrogate the data quality and drive transparency before the model is made. So a lot of what we see in the media and in conversation in industry, for example, is that we've gone all the way through to the deployment of the model and then we test it for bias. And we say, uh-oh, we have an issue. And then it's very expensive. You have to go all the way back to the beginning to retrain that model. And maybe you even need to find new data to train that model. So the opportunity we see is this moment in time here when you have the data set to actually take a look at the data before you've even started to process it. So let's take a look at what the data has, what it doesn't have, the distribution, the collection mechanisms and methods, and highlight any known issues or potential harms before we go much farther. Next slide, please. So, it's not just about knowing the ingredients. It's also about making it obvious what the meaningful choice could be. So when I have a box of cookies, this is me in cartoon form, obviously. The meaningful choice that I have is, should I eat this? For a model, it's going to be a little more complicated. If we have a data set that has a nutrition label attached to it, the kinds of decisions that we want to enable data practitioners to make is not just should I use the data or not, because there's always going to be a problem with a data set. There's, it's no such thing as an unbiased data set, but how should I use this? Are there certain things I'm going to need to keep in mind when I do this kind of regression, or when I'm applying this particular training data and mapping it to a population in production, right? So it's about being able to drive meaningful choice, not just saying I want to use it or not, but how should I actually use it? Next, please. This is just an image of the most recent nutrition label we had actually for that melanoma classification challenge data set that I showed you some of the images from in the beginning. And you can see here that it's very focused on use cases. And also there are some high level pieces of information like badges that will be standard across all data sets. So we're really trying to come up with a schema, and we're currently actually working on our third, so this is already out of date, that will be generalizable across data sets. So similar to a nutrition label, you can take a look at it and make a decision rather quickly. Next, please. Just a little bit more about the kinds of things we're actually looking for. So on the left-hand side, these are the types of questions that we ask about the data set and highlight on this nutrition label. These are potential harms or biases. On the right-hand side, we try to map this to actual use cases so that, again, we can drive meaningful choice when it comes to a data practitioner deciding whether to use a data set at all. Next, please. So finally, just to recap, right? We believe that having some kind of standardized documentation, transparency practice around data sets will drive better data analysis practices because data practitioners can pick up data sets more quickly and understand them. That will then lead to an overall increase in the quality of the models. And finally, if as a data set curator, you're going to have to create a label when you publish that data set, it's also, we believe, going to drive the creation and the publishing of more responsible data sets overall. Next slide, please. I believe that is the end of the presentation. So I know that was very fast, but I'd love to hear any feedback, thoughts, comments. Please do get in touch. And thanks again for having me.
Kasha, thank you so much for that amazing presentation and the work you've been doing. Again, I thought it was enlightening when I saw it in the Duke event, and was glad you're able to participate in today's event. I know John Halamka, some of you have heard talk about the nutrition labels for algorithms. And so I love that this boils it down even another level, saying that we need nutrition labels for the data itself and whether or not the algorithm should even consider consuming that data. So really appreciate that. All right, closing us out with the part 3, the final presentation is a joint tag team presentation. We've got Jaren with the Omega Concern and Dr. Richard Frank with the Siemens Health and EARS. Gentlemen, will you please take us away?
Sounds good. Stefan, can you hear me?
Sounding clear.
Great, perfect. Thanks, guys. Next slide, please. So of fundamental importance to the adoption, implementation, and deployment of artificial intelligence in healthcare and medicine are the business models behind the work performed by machines. Medical practice is part science and caring for patients is part art. However, neither function without economics. AI needs a descriptive framework that is used to develop the coverage that in turn will adequately pay for expert systems, machine learning, and algorithm-based services. So consider how to account for AI challenges to traditional healthcare business models. Because AI is not reflected under existing practice expense methodologies, the best example being CMS. CMS has acknowledged its limitations to cover AI and issued an RFI in the physician fee schedule proposed rule for 2022. And it's a second year running that CMS has openly questioned how to account for AI, particularly the practice expenses. The year before, in 2021, CMS grappled with paying for a diabetic retinopathy AI solution. The issue is timely as the RAND Corporation is helping CMS review data and methodology to establish PE evaluation. Next slide, please. So payment, Medicare payment rates include direct and indirect practice expense. Those values are based off of the Physician Practice Information Survey, which is outdated. It was last administered in 2007 and 2008, way before we actually had tangible AI in healthcare. So emerging technologies do not rely on the typical equipment and hardware purchases, but rely instead on software, licensing, and analysis fees. A great example of that would be pay per click. Coverage and payment is inconsistent and based on crosswalking to payments for imperfectly analogous services, which is what CMS ended up doing with the diabetic retinopathy codes. Next slide, please. So let's talk a little bit about coding, which really gets us to the hard tax. No codes, no description of services. No description of services, no coverage, no payment. The CPT, the current procedural terminology code set, are descriptive terms and identifying codes for reporting medical services. Coding also captures equipment, supplies, clinical services used for billing, and tracking utilization. My apologies, I'm in a hotel lobby and unfortunately I've got some ambient noise. Coding will need to reflect AI as in the work performed by machines, which is why the AMA created Appendix S to the CPT code set as a taxonomy to provide guidance for classifying AI. So with that, I'll now hand it off to my friend, trusted colleague, and co-chair of the AI work group under the American Medical Association's Digital Medicine Payment Advisory Group, Dr. Richard Frank, who was recently named to serve as a new member of the CPT editorial panel. And I also would like to thank ONC for inviting us to this really timely discussion on AI. Thank you. Richard?
Can you hear me? I don't see myself yet. Someone needs to take it away.
Hear and see you now.
Okay, great. Yeah, so thanks, Jaren, thanks to ONC, and thanks to those of you on the call today for your attention. I'll try to give you good value for the time. As Jaren mentioned, the AMA recognized that in order for patients, payers, and providers to gain the benefits of AI, it would be necessary to establish coding, coverage, and payment. And so the digital medicine, could you advance the slide, please? Yeah, so the Digital Medicine Payment Advisory Group, which had been stood up originally to develop coding for remote patient monitoring and remote therapeutic monitoring, which has proven to be so important during the pandemic, they chose to stand up a working group focused on AI, which Sharon and I chair. The responsibilities given to the AI working group you see listed here. We initially reviewed CPT conventions to see whether there was anything suitable for AI. We then identified gaps in the coding relative to a heuristics exercise that is looking out to 2025, what coding we would expect there to be. I mean, what AI products and services we would expect to be out to 2025. We then developed a framework that would encompass those heuristics and have, as Jaron mentioned just now, proposed that taxonomy, which was accepted during the September meeting of the CBT editorial panel. The next responsibility for this working group will be to advocate actual coverage and payment. Next slide, please. This slide is a screenshot from the CPT summary of actions, and I think it's testimony to how important this is. That the AMA chose to release this taxonomy a full year in advance of when it would normally release a new code. And you'll see in the chat box the link that Jaron has put in order for you to gain access directly to this page in order to see what I'm about to show you in the next couple slides. On this slide, though, I want to make it clear that this taxonomy is intended to cover not only AI in the formal sense, like machine learning, but also what we might call expert systems, and that is the advanced use of computer technology in order to augment the role of the physician. May I have the next slide, please? Yeah. So the three categories that are established in this taxonomy include assistive, which you're all familiar with in the form of computer-assisted detection or CAD devices, which have been around for a couple decades. And then the new categories are augmentative and autonomous. And these are intended to describe the interaction between the human and the machine, that is the work done by the machine as facilitating the work done by the human. As you can see some key words in these descriptions here. So assistive is AI, which primarily detects relevant data. Augmentative is AI, which actually analyzes or quantifies those data in a way which has clinical significance. But then autonomy is the highest level in this, which not only detects, analyzes, and quantifies, but actually interprets and independently generates conclusions. And we decided that there needed to be at least 3 levels within that. We considered more levels, but I think the simpler the better, so long as this covers the range of what we expect autonomous devices to be doing. The first one simply develops options based on the interpretation and conclusions drawn from the data and offers those patient management options to the physician for their decision making. The second level actually might initiate some sort of diagnostic process, whether it's sending a patient for a biopsy or some clinical intervention, and yet it will alert the physician who can then either modify that or put a stop to it. The third level, which is somewhat analogous to closed loop devices that we see in use already, the AI would actually initiate the management, and it would only be by the initiative of a physician to intervene that might be interrupted. Next slide, please. And so I want to put these code descriptors in context of regulated devices. The descriptors that are developed for these AI codes will anchor the continuum from the technology as described in FDA-cleared products, and at the other end, the language which is used in coverage and payment. And so the taxonomy was developed primarily to characterize the relationship between the work done by the machine and the work done by the human, but it also is relevant to the technology as it will be described with supporting clinical evidence in order to gain FDA clearance to enter the market. And it should lend itself to coverage and payment and, in fact, valuation as well. So this taxonomy, this framework for AI code descriptors, anticipates what features there will be, as well as what business models there may be in order that it anchors this continuum. Next slide, please. And so where we are now is that taxonomy has just been made effective from the first of the year, and therefore it will be used with effect from the very next CPT editorial panel meeting in February and all subsequent meetings. We intend to publish and socialize an article that will actually provide context for that taxonomy in order that it can best be used by developers and clinical specialty societies. We will then develop a set of educational publications and webinars in order to further raise awareness on the best utilization of this taxonomy. And ultimately, we may actually develop a new segment to the code change application to incorporate specifics of AI, given the high level of innovation in these products. So with that, I will thank you again to the ONC for the opportunity for Jaron and me to present this. And thanks to each of you on the call for your attention. Back to you, Stephen.
Thank you both, Dr. Frank and Jaron, for serving also as co-chairs of the AI working group under the AMA. And thank you to the AMA for hosting that community to work on these issues. We're going to go ahead and transition to a break now. We're going to do 5 minutes and come back at the top of the hour. We're slightly off schedule here, but instead of cutting time out of the panel, I'm going to cut it out of my introductory remarks when we start up again after the break. So I'll penalize myself here. And so we'll see you back at the top of the hour at 4 p.m. Eastern. Thank you, everyone. Okay, welcome back, everyone. We're going to go ahead and get started with our closing plenary. We've made it to the final, the big grand finale of the day. We know it was a lot of content throughout the entire afternoon. We really do want to thank all of our showcase presenters and our open plenary speakers as well. Look forward to posting all of this material as well, because we know there's a lot that people are going to want to follow up on. Before we get to the panel discussion, I just wanted to quickly mention, again, I'm going to cut my remarks a little bit short here, but as a review of the day, you heard countless government agencies, showcasing work that they're doing to ensure the responsible use of AI in healthcare. It truly does take a village, and all of our agencies are working together here on the federal government side. And we're doing it by developing guidelines and principles, funding research and pilots, providing other technical resources that the industry can take advantage of, and not to mention, in some cases, flexing our regulatory and oversight role that we have. The other half of the presenters that you heard from were from our non-government health IT stakeholders, health systems, startups, not-for-profits, et cetera, who are also developing industry consensus-driven standards, guidelines, and principles, both as a community, but also even as individual organizations just for their own purposes. We saw that there was a lot of different use cases. They're endless for the applications of AI in healthcare, both on the clinical side, where it is directly dealing with deciding care and treatment, as well as on the administrative side with administrative transactions. And it takes different approaches to try to make sure that we are still mitigating the potential harm and risks that can come from these things while still realizing its full potential. So although today was full of promise, there's a lot of great work that was showcased, and we're excited about all of that. Hopefully it gives all of you some level of comfort knowing that there are brilliant people working on these challenges and trying to ensure that AI is being responsibly deployed in healthcare. I think we also saw potentially some gaps and understood that there's still work that remains to be done. And hopefully, as I segue to our closing panel here, they may touch and give us a little bit of a sense of that work that remains to be done. So with that, I'm going to turn it over to my colleague, the amazing Catherine Marchesini, who serves as ONC's Chief Privacy Officer. And she will be moderating the panel where we have John Halamka from the Mayo Clinic. We have Amy Hall, Health Staff Director from House Ways and Means Committee, Fred Rockman, who you saw earlier from Align Chicago, and also Rohan D'Souza, the Chief Product Officer from Olive. Catherine, they're all yours.
Great, thanks, Stefan. Good afternoon, everyone. And so for those that are sticking with it, thanks so much for investing your time today on this Friday afternoon. As Stefan mentioned, I'm Catherine Marchesini. I serve as the Chief Privacy Officer at the Office of the National Coordinator for Health IT. Welcome to today's panel. ONC has long been attentive to the development and use of advanced and emergency technologies at the intersection of the collection, analysis of large data sets from various sources. That interest, you probably heard a lot from our colleagues today. We started the afternoon's plenary sessions with presentations about responsible, trustworthy AI, and we also heard a lot about the various opportunities, particularly in clinical care, treatment, and healthcare delivery areas. So I thought we would finish today's discussion at the intersection of those two kind of large categories, particularly focusing on responsible AI in the context of what we heard throughout the day. Today, I'm joined by 4 esteemed individuals who will share their insights informed by today's earlier presentations and areas that we can keep our eyes on as we look to the future. So Rohan D'Souza, Amy Hall, John Halamka, and Fred Rockman, thank you all for your time today. As the audience members individually reflect on what they've learned today, I'm going to ask each panelist, we have about 3 minutes each, to share their thoughts in response to a few questions informed by today's presentation. So let's get started. So we heard about different approaches to having responsible, trustworthy, we've heard transparency, explainable, fair, and accountable in healthcare. And there's a lot of variety that's out there with different methodologies as well as frameworks. John, Fred, Rohan, can you give your experience and expertise, how you would compare and contrast these with the different approaches that you heard today on how to handle AI, as well as overall data model risk management in this area? Let's start with John.
Well, what a great question, and thanks for having me. So first, let me just reflect this entire program represents a perfect storm for innovation. I've written that when you have alignment of government, academia, and industry and an urgency to act, you're going to get innovation. So congrats for what you've done today. If I look at the challenge ahead, I'll break it into two issues. Question is, if we are going to have a marketplace of algorithms, how do we ensure that there is transparency? Is there a rubric by which we can say for a given algorithm, just as we heard from Kasia about a nutrition label, that we can say, oh, this algorithm was developed in the following way with the following data sets, has the following performance characteristics. So that transparency is really important. But the second thing is, we know there's such things as data set shift, local tuning, and then an algorithm developed for one population may not work in another population. So we need monitoring. The question is, what should we monitor? What should we measure? How should we report it? And those are going to be very interesting, both startup and regulatory questions that we will all have to work on together. I have no doubt that 2022 will be a seminal year where we come out of this year with a set of measures to describe transparently what an algorithm does and a set of monitors to ensure we can measure its performance over time.
Great. Thanks for that. Fred?
Yeah, I guess I'm just, first of all, gratified by the consistency across the day with which people pointed to some of the rails and guidelines that need to be around our approach. That we need to have an eye on safety, on transparency, on equity, on consistency. We need to have a mind to watching the quality of data and the breadth of data that's populating our algorithms. We need to guard against the fact that AI improperly introduced could actually perpetuate or accelerate bias rather than the opportunity that we heard that it could actually be a tool to decrease bias in healthcare. So all of these, it was reassuring to hear that we recognize those things. And of course, the challenge is, how will we be able to recognize those things in the translation of AI into practice? I guess one more thought is, if AI is in a marketplace, how can we safeguard that the prioritization of development of AI will be equitable? It will respect needs of populations broadly and not just be driven by marketplace advantage. So those are just some random thoughts.
Random is always good. Rohan.
Yeah, thank you for having me. And similar to what Dr. Halamka said and what Fred just mentioned, I did very much enjoy the consistency across the rhetoric and the narrative throughout today. There are some incredible frameworks that are being created and shared. I want to maybe take us down a little bit of a different path. I'm representing the private sector today. One of the hardest things that we have on the private sector is realizing the implementation cost of changing culture and being okay with achieving parity on an existing baseline where an interpretability of AI might present you with some very unique questions that force you to think about your current ways of being altered. And so, in AI, we always shoot for V1 of a model is always trying to be slightly better than baseline data. And sometimes baseline data is tribal knowledge and human expertise over many, many years. And so when the first model comes out with beautiful interpretability that companies like mine can take and present in fantastic experiences, to be at the ready to handle the questions that will come and say, oh, that's really interesting. I had no idea that this particular data point could be clinical, financial, demographic, social determinant of health, whatever, is adding or providing some weight into an outcome metric of how long we think a person is going to stay in the hospital, because you're not trained that way. You're perceived to take clinical guidelines through a standard process of oversample cohort studies, which ML and AI literally challenge that very status quo. So I think there's so much amazing stuff happening on the technology side, and the ability to access all of this compute power. It has, the barrier to entry from a cost perspective has been fantastic. It's the cultural shift and this coming together of public, private, academia, as Dr. Halamka mentioned, to really move the needle on this is going to allow us to see who crosses the chasm.
Thank y'all for sharing your reflections and insights on that. And I would really be, if we have time to hear a little bit more about the cultural shift, if that's okay. But first, I wanted to let Amy to share her thoughts and reactions to today's discussions of AI and the health industry as well, and mention anything she may wish she had heard about, or how she feels about the industry when they're trying to consider more of what to look at to support the responsible use of AI, given the Ways and Means Committee recent report intersecting with this area. Amy.
Thank you. And I just want to say thanks to you guys for holding this forum. I think it's obviously timely, clearly by the interest, and there does seem to be a lot of consensus, or you hear a lot of the same things, and particularly from our perspective, what we're interested in is transparency, accountability, and any biases. Earlier in the program, you guys heard from someone else on the Ways and Means Committee, Dr. Rachel Dolan, who talked about our work in one small area, which deals with racial bias in clinical algorithms. And I guess I'm not a data person, but the data people say garbage in, garbage out, right? So the problem is when you're looking at the foundational aspect of all of these algorithms, of all of these AI products, is data. And I think we need a better understanding of the biases that come in with the data and the biases that come in as these algorithms are being developed. I mean, I love this idea of like a nutrition label, for these products, so people really know what they are buying. But from the public program perspective, from where we sit on the Ways and Means Committee, transparency is also important. And I think the real challenge there is that we shouldn't be paying for things that can become tools of inequality, and as opposed to tools of equality. And we shouldn't be paying for things that we don't understand how they are being used. One of the things that I didn't really hear about today, although I thought the American Medical Association discussion about coding is really interesting, because at some point, some of these AI systems are going to become substitute coverage decisions. Right? They are going to substitute for the function of the insurer, because they are going to guide care. And I, as the patient, may get something or not get something. The provider may offer me a service, or if it is, for example, an insurance company captured AI tool, I may not be offered a service because the algorithm sets it up in a way that it is not recommended, is not provided for me. And what does that mean? When does that become a coverage decision? And as a patient, if I say, yeah, I know your algorithm says this, I know your AI tells the doctor to do that, but there's another host of services that are not being offered to me, is that denial of those services? Is that a coverage denial? Like, how does that work from the consumer standpoint? And I think, I know that's not 100% the focus here, but insurers and payers use these kinds of systems all the time to determine what care they are going to pay for. And at some point, that action gets substituted for clinical decision-making. And what does that mean? And how does that impact the beneficiary down the line? So that is one thing that I hadn't, I don't think you guys were intending to cover that, but I think it would be something good to explore. And I could go on forever, but I'll let you keep going through your panel questions.
No, I appreciate that. And I wanted, I guess, to offer it up to any other panelists, any reactions or thoughts to what Amy shared about maybe one of the gaps that were discussed. I think there may have been a little bit of chatter in the chat about it. I think there were some audience members that had said, you know, healthcare payers have been using this for years. Just wanted to see if any panelists had any thoughts or reactions to Amy's comment.
So Amy, I guess here's the interesting question. There are three terms of art we use when we use AI algorithms. One is transparency, right? When we developed it, how do we do it? What was the data set, the nutrition label? One is explainability. Can we actually tell you what it's doing? And that's pretty challenging, especially with deep learning methods. But another is testability. So you can imagine as a clinician, I'm an emergency physician. If I tried an algorithm 10 times and you know I got 10 pleasing results, the capacity to test it and feel confident about it is also important. So building an infrastructure that encourages this sort of almost Yelp-like testability and comment will be just as important as transparency.
Yeah, I have a kind of an opposite perspective. I do think we do need to be concerned that if we're using AI as quote a replacement for more traditional or human forms of medicine, that it's actually an advantage for patients, not just something that's cheaper or more convenient. But the flip side is also true. I mean, we've seen the introduction of AI-enabled devices that are clearly evidence proven to be beneficial and actually lead to better clinical outcomes. And there is a lag in how, for example, public insurance has been able to evaluate it and make it available. So I do think it was interesting to hear about that taxonomy for CPT coding. I think it is a really important issue for being able to make AI practically available, how we will be able to weigh the approval of these tools for reimbursement.
And if we have continuous, one quick comment, if we have continuous testability, what threshold will we use for success? I was talking to some industry leaders about self-driving cars, and they said, you know what? Imagine that 1,000 auto accidents occur a day from humans, and one accident occurs today from a self-driving car, yet the media covers the self-driving car. So is 1,000 times better than humans good enough or not? No one knows.
Amy, were you going to say something? I wasn't sure.
Yeah, I mean, I think I was just going to add the other point, because the conversation about CPT reimbursement made me think about this, is that, you know, and somebody on the previous before the break was talking about these products being used. I think the word was for market advantage, which is another nice way to say profit. And I also think from the Medicare program perspective, we need to think about, as these are getting incorporated, as this technology gets its own CPT codes, is Medicare paying to help people figure out how to make more money off of Medicare? Or is Medicare really paying for clinical outcomes and care improvement? And there's probably some mix of both, right? And I think different products will fall in different places on the spectrum, but I think that's something that we have to be careful about, you know, to the extent that people can, providers will have a tool that tells them to do X, Y, and Z, but X, Y, and Z gives a whole bunch more tests or a whole bunch more treatments to the patient because that maximizes reimbursement under an existing system, right? So we need to think through that too. Like, are we now paying for something through the Medicare program that is profit maximizing? And, you know, I think you guys have really been talking about maybe individual clinicians today, or at least it seems to me, but I think you also think about larger institutions, whether it's a nursing home, and some of these tools being used to determine staffing, being used to determine patient care, which isn't always, if anybody's been tracking what's going on in the nursing home space, isn't always leading to optimal outcomes, but it is leading to optimal, this is so not my market advantage. So something else to think about.
Great. Oh, great. Great discussion. So I did want to talk a little bit about the future. So it seems like that could be a topic area we could explore potentially with our colleagues at CMS, but other areas we may need to go. So we heard from the FDA and about expectations to provide guidance to regulated AI-enabled medical devices. However, I'm sure many of you know a lot of the emerging technology and used in healthcare, including AI, may not meet the definition of a medical device and therefore would not be captured in the FDA activity. So I guess to all our panelists, as our industry moves forward with pursuing responsible use of AI, how else can we make sure AI is used for affirmative, positive purposes, including to advance or improve health equity for patients? Are there lessons we could learn from other industries to help us realize the full potential? So basically, what is needed to get this right across the healthcare industry? Fred, let's start with you and then open it up to the rest of the panel.
Thanks. A couple perspectives. First of all, it was really gratifying to hear that you included thoughts from our colleagues in Canada and Great Britain. I think there's opportunity for us to learn from and be part of a learning community from a broader than just within the United States. Something that concerns me is I think we might be in an era where our social intelligence might be challenged by our technical and scientific capabilities. I was really struck by the simplicity of Devin Willis, saying, be truthful, don't overrepresent, and be transparent. That seems like such good, solid, basic advice in how we implement going forward. So I think, that benchmark is going to be important. And then the other thing is we know that the influencers of health are much broader than what we typically have focused on within medical care. That medical care and genetics are responsible actually for a smaller part of the outcomes of healthcare. And therefore, this database that we include in predictive algorithms there's a real danger that it can be way off. If we go into territories that purport to be including all of the relevant data but do not. You heard some examples of both positive and negative of that today. So I think if we focus, like we are careful not to get ahead of ourselves. So there's certain observations that are crisp and clear that can be used to develop AI, that we're sure that we're including all the relevant data and that it's objective, those we could advance. And the ones that require more complexity in what should be included to feed those algorithms, to be exercise caution and rely on those principles that we heard about today.
So Fred, I totally agree with you about the notion of we need principles, we need guardrails, we need guidance. As I talk to industry leaders, they say, you've seen enough bad sci-fi to know that once we release the AI, the robots take over humanity, right? I mean, and I say that jokingly, of course, because it's up to us how we implement this stuff. You could imagine as a clinician that if I got an AI algorithm to help me with a diagnostic dilemma, it's, there seems to be a 64% chance it's this disease, 27% chance it's that disease. That is actually value added to me. It helps me think through probability. However, if the AI algorithm just does the diagnosis on its own in a closed loop fashion, that could have high risk. So it'll be fascinating as we look as a society, how these things are actually put into practice. Where is there a closed loop system where the AI takes action, or where is there AI that is simply augmenting a human decision-making process?
If I can just extend a little bit, maybe apply a software development lifecycle angle to this. AI-based software development is, I think, the first time where we clearly branch off from the traditional deterministic software engineering lifecycle, right? Dr. Halamka, you called out creating a system that provides testability. And the testability sometimes is in an extremely long period of time where it can be really, really restrictive if we enforce too many restrictions or standards in place that prevent us to make changes on the fly. Because a machine learning model, once, it's sort of like driving a brand new car off the lot. The first time when it goes into production, the value of it immediately drops because you couldn't have possibly thought of every single real world scenario in your testing. And you're going to have to go through a pretty rigorous in this testing process of constant change. But if your certification forces you to say, sorry, it's a one-way door, it's locked, you can't really make those changes on the fly, you're now in this constant cycle of making changes, requesting for approval, making changes, requesting for approval, when really it could be a matter of including a single column in a classification model or a new feature vector in your model, right? So it gets, I think, I don't know the solution to this other than I don't think traditional solutions of deterministic software development lifecycle can apply here.
I mean, I'm not. Go ahead. I would say I'm not sure I have all that much. I'm not sure I have all that much to add to that. But I think I agree with Fred particularly points about when we build from the ground up, we have to pay attention to what it is that we're starting with. So. The other piece I would talk about is patient preferences, right? Sometimes there are many, this conversation sounds like there's a lot of absolutes, that the decision that is made through an AI model is the decision because it's made by AI and it's a good decision. But sometimes even the best decisions, as anybody may know from having a loved one who's had any sort of serious illness, sometimes patient preference is equally valid and an equally appropriate outcome that may not be where your model directs you, right? It depends on what you're optimizing in your model. And so I think folks need to figure out how to ensure that patient, respecting the patient's wishes, and that there is ability to deviate, and that it isn't so absolute as a tool.
So Amy, that's a really great comment. And I talk to data scientists and say, if an AI algorithm told you to do something, would you? They said, well, it's just one element in my decision making. When I talk to some who are, say, unsophisticated about the power of AI and how these models are actually developed, they say, oh, if an AI said it, it must be right. So there's a huge amount of education we're going to need to do to ensure these things are deployed appropriately.
Great. Well, I think that's a great way to end the discussion. I know there was a comment earlier about culture shift. I think this is an area where there's a multidisciplinary approach. And I know there's some conversation going on in the chat about software development and data scientists, and there's not necessarily different skill sets and trying to bring everyone to the table as part of the development and use of AI. I wish we had more time. I'm getting cued that we're out of time. Great discussion. John, Amy, Fred and Rohan, thanks for the brief and lively discussion and reflecting on where we've been, where we can go as we look to the future. With that, Stefan, I'll turn it back over to you.
Great. Thank you so much, Catherine, for doing a great job moderating our panel as usual, and to all the panelists for providing such great color commentary in usual energetic fashion. So really appreciate that. Also, thank you to all of our presenters throughout the day. Thank you to all the attendees for taking the time to carve out an afternoon and spend it with us learning about this. We're sure some of the presentations resonated well with you and the work that you're doing. Maybe some of them you didn't quite get because it wasn't your area of expertise or what you look at AI in your world. But hopefully you learned something new as well through many of the presentations. That's our goal, is to kind of try to show a full spectrum of different perspectives and different stakeholders who are working on this issue in different ways. And just know that there's a full community out there that you can work with and help support. And so hopefully you'll be able to reach out. We will be posting these slides on our website at the same page that you registered for this event on. We'll be posting those slides as well as the recording from the session. And if you have any other questions, feel free to reach out to myself and I will do my best to get you an answer or route you to the right people who could. As usual, ONC is here to help play a role in kind of coordinating and working alongside and supporting all of our family of stakeholders across the board. So thank you again. And we look forward to our next discussion on this topic in the near future and work to continue throughout 2022 and beyond. Thank you so much.